We'll continue. Okay, so next question. There's a patient with normocytic, normovolemic anemia and low platelet. Blood results were given diagnosis. We have discussed these leukemia types, right, earlier. Now tell me what do you think in here? Normocytic, normovolemic. Okay. What do you think? Okay, so you all know how multiple myeloma present, right? If it is multiple myeloma, there should be more symptoms, right? CRAB criteria should be there, right? CRAB criteria should be there. What about AML? Acute myeloid leukemia. What do you know about this AML? AML usually can see in adult people, right? Can see in adult people. What else do you know about this AML? It's a what is it? It's an acute case, right? Acute myeloid leukemia, right? Acute myeloid leukemia. So, what is happening? It's a myeloblast proliferation, right? So, there can be anemia, thrombocytopenia. These things can be common in this AML, right? AML. So, AML. So, what you can see in here, it's acute disease. So, you can see here highest amount of the blast cells, right? Blast cells. Yeah, these are the things. So, how ALL present, ALL, you can see in where that day also I told you, remember, all in children and call in all the people, right? Call in all the people and all in children, right? Most common in children. And the anemia, thrombocytopenia, those things can be present in ALL, right? So then what else? So here also you can see the blast cells, right? The acute case. What else, doctors? Okay, so blood film, what you can see in AML. That day I have explained. Tell me, doctors, what do you think? Quickly tell me. That day we have done some images as well. Aura rods, right? Aura rods and myeloblast, you can see, right? Okay, so from these two, what you can think? Is it AML or ALL? What do you think? AML or ALL? They have not given the patient is adult or a child, right? They have not mentioned it. So what do you think? Because we don't know the blood result as well. So in that case, this is kind of incomplete question, right? Because if it is a because both can see these normocystic normulemic anemia and low platelet, right? Are you there, doctors? Tell me your opinion because we have discussed these things. So it seems like this question is like not very completed. So because we have to choose from these two AML and ALL, so you need to know the child is a child presentation or adult presentation, right? Adult presentation. But like we can think about AML, but you never know, right? We don't know the scenario. Anyway, multiple myeloma is out. We have discussed how it presents. It's a different scenario, right? Okay. So like that. It is a chart. You can give it a read how it present. Okay. Doctors, can you give me like a 1 minute? I'm just kidding. Please read these two question and write the answer in the chat. Sorry, doctors. Okay, so what do you think in this Yes, pain during eating. So you all are like, do you have any doubt with this question? Because this is incomplete situation and we have just discussed about this ALL and AML, right? So I hope there's no problem with this because you need to know because multiple myeloma discuss AML, AL, all things discuss. I have again attached this chart as well. So that's what I'm okay. No, no, doctor, we just started. We just started, okay? So here pain during 18 talking and touching one-sided maxillary tenderness, most likely diagnosis. They have given trigeminal neuralgia, dental abscess, and a woman with several episodes of burning facial pain on the one side, previous episode of headache, tenderness and palpation of maxillary area. Diagnosis, okay. This is the thing that they have given. So what do you know about? So or you all choose it as a trigeminal neuralgia, right? Trigeminal neuralgia. So, what is this trigeminal neuralgia? So, trigeminal neuralgia is a recurrent unilateral brief shock-like pain you can see, right? Then it involves one or more divisions of the trigeminal nerve and caused by demyelination or neurovascular compression, right? So, assessment is request imaging to exclude the structural cause and imaging is especially important if there is a sensory loss which suggests trigeminal neuropathy, right? And asked dedicated views of the trigeminal nerve and ganglions. So the management, drug therapy is the first line, right? So what is the drug therapy that we can use in here? What is the type of drug therapy that you can use? Tell me the first line drug. This topic, the trigeminal neuralgia, has repeated on May as well. Quickly answer, doctors. What is the choice of the drug that we are using here? Trigeminal neuralgia. Okay, here we have what? Carbamazepine, right? Carbamazepine, oxycarbazepine, and the second line pregabalin, right? Pregabalin. So when you should refer this patient, all this from the TG, okay? If there's a poor response or intolerance to adequate drug therapy, loss of efficacy, diagnostic uncertainty. In that case, you have to refer this patient, and we have surgical options under a special setting, so microvascular decompression, percutaneous rhizotomy, and stereotactic radiotherapy, right? Or gamma knife. These are the other options because these surgical options after referral. So this is the indication for the referral, and this is the drug therapy. Drug therapy is the first line treatment, and this is how the trigeminal neuralgia is present. Right here. A scenario 53-year-old man present to the ED, worsening of pain along his lower left mandible. The pain is incredibly intense, paroxysmal in nature, and lasts for a few seconds to minutes. The pain is triggered by shaving and brushing his teeth. However, in between episode, he has no residual abnormal sensation. His medication history is significant or hypertension, and he has 40 pack years smoking history. On examination, his blood pressure 140 by 85, pulse 75, SpO2 98, and light palpation of the lower mandible in the patient. Suddenly, means pulls away in patients and pain and describe the continuous dull ache lasting approximately 60 seconds in the area. The cranial nerve examination performed and otherwise normal despite hesitancy from the patient not allowing the area to touch again. Right, so they're asking which one of the most appropriate. So carbamazepine, very important, okay? So patient has a trigeminal neuralgia. So yeah, trigeminal neuralgia, the clinical scenario they're explaining. The exact pathophysiology is not known, but the patient vascular compression due to trigeminal ganglion has been implicated. The pain response to medication used treat neuropathic pain about 70% of patients, and traditionally the carbamazepine is the first line, right? Okay, so neurological referral may be indicated if MRI brain image suggestive of intracranial pathology such as the vascular compression or trigeminal ganglion mentioned above. Okay, so remember carbamazepine, very important. This is all from TG, very important. Okay, next question. Okay, well, mark the questions. Okay, now tell me how cluster headache is present. How cluster headache is present. Quickly tell me. Quickly, like give me idea how what are the clinical features, how cluster headache is present, how these cluster headache present. Tell me, doctors. Cluster headache, what are the features of cluster headache? Okay. Yes, severe unilateral headache, right? And patient can be associated with the autonomic symptoms, right? Autonomic symptoms like what are the red eyes, right? Runny nose, then lacrimation. Those are associated, and you can patient is having the retro orbital pain, right? Orbital pain is very severe orbital pain patient can associate it with, right? Then this episode is lasting around 15 to 180 minutes, right? So yeah, like that. So these are attacks, right? Yes. Then how this migraine present? Migraine. What type of headache is there? Migraine is a throbbing and pulsating headache, right? It also usually unilateral, right? Usually it can last 4 hours to 72 hours, right? 4 hours to 72 hours. And like other features, photophobia, right? Phonophobia, aura. In some cases, you can see, right? Nausea, vomiting can be associated, right? Okay. So that is something different. So you should know how to differentiate each of them, right? Okay, so next one, hypercalcemia, vitamin D normal, TSH normal. What would be the next investigation? PTH, what do you think? Why PTH? Why PTH, doctors? Doctors, can you like give me 5 minutes? I will reduce it from the break because I really need to get a very urgent call. So yeah, can you please read this? No. Okay, please take a 5 minute break. I will reduce it from the other break. Okay, so just give me a very urgent. Hello, doctor. Sorry for that. Yeah. I just end the call. It's a very urgent one. Thank you so much. Okay, so we will discuss. So, what do you know about this hyperkalemia? Sorry, not kalemia, hypercalcemia. What do you know about hypercalcemia? So, first of all, you need to know how this calcium regulation is doing by our body, right? So, how it going? So, calcium is controlled by three main factors, right? Parathyroid hormone, vitamin D, and bone turnover, right? Bone turnover. So these three mechanisms are the one that control the calcium metabolism in our body. So what is the action of this paratha hormone or parathyroid hormone? So what is the action? So it increase the calcium resorption from the kidney, then increase the bone resorption, then increase the vitamin D activation and increase the gut calcium absorption, right? It has a power to increase the vitamin D activation, right? And all together they are raising the serum calcium, right? So pathophysiology of hypercalcemia, right? So we know the mechanism, right? Resorption from kidney, bone resorption, and we have activated vitamin D that can increase the gut absorption, gut calcium absorption too. So if something is increasing these three mechanisms, that can lead to the hypercalcemia, right? So increase bone resorption, increase intestinal absorption, and reduce renal excretion. So these are the three things that can be associated with what associated with the hypercalcemia, right? Okay, so okay, if you find out there's an increased level of calcium, so what you need to know, you have to find out what is happening, right? What is happening? So we have primary hyperparathyroidism, right? That is the most common outpatient cause, the most common cause. So what is primary? Primary mean the gland itself, right? Always the primary means the the gland, right? As the associated gland. So parathyroid gland. The problem is parathyroid adenoma, right? Parathyroid adenoma, right? Okay. Parathyroid adenoma. So excessive parathyroid hormone. So what is happening in here? What is happening here? If there is a adenoma and it can produce the excessive parathyroid hormone, right? That can lead to the increased osteoclast activity, the bone breakdown, increased renal calcium reabsorption, and increased vitamin D activation, right? So result in chronic to mild moderate hypercalcemia. So this paratha hormone level is high or inappropriately normal, right? Inappropriately normal, right? Okay. So like that. Okay, then. Okay, and now tell me, okay, here parathyroid. This is management. If there's a parathyroid here, yes, parathyroid hormone. Definitive therapy is the surgery treatment because if there's adenoma present, what you need to do, you need to remove it, right? So definitive treatment is surgery, which cures 95% cases and has low morbidity. A watch and wait approach. There's another one is watch and wait approach can considered instead of surgery in patients who are 50 years or older and have total serum calcium concentration corrected albumin lower than 2.9, normal kidney function, and no nephrolithiasis or nephrocalcinosis, and bone mineral density is higher than minus 2.5 and no symptom. This is something else. So if it is a primary hyperparathyroidism caused by this adenoma, you have two treatment, watch and wait, and the definitive surgery, right? So you need to know what are the indication that we are going with watch and wait, right? Then other than that, we have malignancy associated hypercalcemia, right? Because there's a mechanism as example like lung cancer, breast cancer present, they can produce parathyroid hormone like peptide, right? These are not parathyroid hormone, but they are acting at it as a parathyroid hormone. So they are acting fully as a parathyroid hormone, and that can increase the calcium level from these above three mechanism, right? Because the function is same, but the The structure is only the different thing, right? And other than that, from the, if there's a cancer present, so bone metastasis can be present. Because of that, direct osteolysis can be seen. That also can increase the hypercalcemia, right? Then other than that, other features like vitamin D excess. Vitamin D excess mean increased gut absorption of calcium, right? Vitamin D excess mean higher vitamin D level activated by this the parathyroid hormone, and it can increase the gut absorption, right? Due to excess supplementation, granulomatous disease, or reduced renal excretion, thiazide increased calcium resorption, dehydration was hypercalcemia. So these are the features or other things. Okay. So usually parathyroid, the actual hormone dependent in primary hyperparathyroidism and tertiary hyperparathyroidism, right? So then we have parathyroid independent. That means the problem is not with the parathyroid hormone like cancer, this vitamin D, immobilization. You can remember it as like that. Okay, vitamins trap. Just give it a read because other diseases like sarcoidosis, neoplastic related diseases, rhabdomyolysis, like these diseases also associated with the hypercalcemia, but it's not the mechanism from the parathyroid hormone. Okay. So what are the clinical features that you can see in here? Stones, bones, groans, psychiatric overtones, right? So everyone know how it presents: renal stone, bone pain, constipation, abdominal pain, polyuria, confusion, right? Depression, those are the associated symptoms, right? So stepwise investigation, you have to confirm the hypercalcemia first, then you have to check the parathyroid hormone level to check whether this is parathyroid dependent or independent, right? So after checking the parathyroid hormone, if the parathyroid hormone high or normal, high or inappropriately normal, so you can think about primary hyperparathyroidism. The problem is the adenoma, right? If the parathyroid hormone low, that means there's nothing associated with the parathyroid hormone. You have to find out the other cases, right? Other cases like that. Okay, so the treatment also I will explain. The initial rehydration, the acute severe hypercalcemia, if it is more than 3, often cause dehydration and electrolyte depletion, so leading to the deterioration in kidney function that increase the serum calcium concentration further. Rehydration with sodium chloride infusion is essential, right? Sodium chloride 0.94 to 6 liters by intravenous infusion over 24 hours, right? So very important. Other than the additional treatment, what are those things? In severe hypocalcemia, child does not respond to adequate rehydration. You have to go with the specialist advice. For the pediatric, for adult, severe hypocalcemia has not responded to the initial rehydration, you can use intravenous bisphosphonate infusion to temporarily lower the serum calcium concentration before starting the bisphosphonate. So, before starting bisphosphonate, take a blood sample to measure the patient's parathyroid hormone concentration to help the determine the cause of hypercalcemia, right? Because then only you can get an idea it's a dependent or independent case parathyroid, right? So these are the options. The first line, the solendronic and pamidronate, you can give as additional treatment if the initial hydration is failed, right? Initial hydration is failed. Um, yeah, acute life-threatening hypercalcemia, consider parenteral calcitonin, salmon in addition to the bisphosphonate to achieve the more rapid effect. So you can give calcitonin salmon 100 international units subcutaneously as well. Okay, so yeah, that is a general one. Other things I'm not going to read because that is going into different diseases. If it is a vitamin D toxicity, how it present, and if it is a granulomatous disease, what to do, like that. Okay, if it is associated with cancer, also I have attached. You can give it a rate because today topic is not the cancer related one. Okay, because in previous months, I think March and April, we got the cancer related hypercalcemia, right? Here the hypercalcemia, vitamin D normal, TSH normal. What to be next investigation? So you already find out hypercalcemia, then you have to get idea about is it parathormone dependent or independent, because you have to understand if it is the due to the adenoma or not, right? Then after, if it is dependent, you can do the further test for the parathyroid adenoma. right? So we have that question answered because in the May also they have asked that question. I will explain once we get the question. This is why it is there. Okay. So the next question. So give it a read those things. Okay. Because important parts are highlighted. So target esophagus treatment. So what do you think? What is this? What is this, doctors? What is tortoise esophagus? So what is happening there? So what is it, doctors? What is happening there? What is happening? 1 minute. Okay. Okay. What do you know about this tortoise esophagus? What is happening there? Okay. So, no, that is different, doctor. So, tortoise esophagus, this is a new topic. So, it's a serious problem, came from the chronic achalasia. It's a disorder that stops from food pipe from relaxing, right? Over the time, the pipe get very wide and twisted, making it hard to swallow. It's a rare disorder, affect about 1.63 people over 100,000. It's a big challenge. No. So, what are the key features? Tortuous esophagus usually comes from untreated or long-term achalasia, right? The condition make the food pipe very wide and twisted, make digestion hard, right? So this is a complication from long-term untreated achalasia, right? Long-term untreated achalasia, right, doctors? It. Yeah. Okay. So studies show no need that part. Okay. So here I'll show how this came, how this come to here. 1 minute. It should not be here. It's fine. I'll remove it. Okay. So we'll do this question. We'll do this question to get an idea about 38-year-old man present to GP clinic gradually worsening dysphagia and frequent regulation of the food while eating at night. Over the last few months, he had a dropped 2 pound size even though he has not been trying to lose weight. He otherwise has an insignificant medical history. He is referred as specialist and undergoes endoscopy to subsequently rule out malignancy. He's sent for the esophageal manometry and which indicate has excessive lower esophageal splinter tone and intermediate periods of paranasophageal pressurization. So when asked, he explained that he want the procedure, does not want to repeat interventions. He also want a procedure that is a minimal side effect. So which one of the following most appropriate plan of man? This is what is the diagnosis in this given scenario, doctors? So what is the diagnosis in this given scenario? Tell me what is the diagnosis? Yes, achalasia, right? Achalasia. Right, doctors? So, why he's going with the laparoscopic hematoma? Let's see. This patient has achalasia. There's a number of factors considered which will help to decide the most appropriate plan of management. These factors include the age and general state of health of the patients and manometric finding. When the considering the treatment option, the patient must be counseled that none of procedure will be totally free of side effect and further correction might be required in chosen procedure. Right? Okay. So, however, some procedures will have less side effect than others, and some will have better likelihood long term. So, per oral endoscopic myotomy. Incorrect. Why this is a first line option for the surgical management of achalasia. However, it has significant risk of gastroesophageal reflux disease. So, post procedure for this reason would not be offered in this case. Right. So numeric dilation of the esophagus. This is a management option for recommended people with type 2 achalasia, and however, it is more favorable as a response in people over age of 45 and those of female sex, right? There are high risk, high likelihood that this patient would need further interventions as remission only 5 to 10 years, right? So then, Botox injections a non-surgical management for achalasia, while it is possible management option for type 2 and generally recommended for patient not fit for the surgery or as a bridge for more definitive therapy. Okay, laparoscopic myotomy. This is an option for the surgical management of the achalasia. This patient type 2 uh, and would be classified as level 3 as per Eckert score. I'm not going to explain the achalasia, the stages and those things, but I want to give an idea about the treatment. Okay, the recommended management of type 2 achalasia is a pneumatic dilation, helematomy or POEM. So he has a younger and otherwise healthy, so good candidates for helematomy. So usually they are just asking is management, then you have to think according to the given factors, right? The patient's age and severity, those in. Then fundoplication. This is a surgical management offered for patient with gastroesophageal reflux, right? Okay. Okay, I'll show achalasia types only to get an idea. Yeah. If we get the topic, I will explain. Okay, I can attach it to you to get an idea, okay, about this treatment and all. I don't know, sometimes it's very hard to deal with this. So now I'll attach here. Okay, and this is about some treatment for achalasia. Okay, let's see the link between achalasia and esophageal distortion, right? Okay. So achalasia is the biggest reason for this twisted esophagus. In achalasia, the nerve that can control muscle movement get damaged. This makes hard food to move down, causing the esophagus to stretch, right? So this stretch puts a lot of stress on the tissue and it can lead to this loss of muscle contraction and higher pressure in the esophagus, and the esophagus started bend and stretch. Okay, there's a no proper guideline for this one. This is I think there's a UK guideline I got. Okay, there's a no guideline or nothing mentioned about this one in Australia, and no emergency as well. Okay, so but I found out this is UK guideline. So mechanism lower esophageal sphincter dysfunction. The lower esophageal sphincter control the food. We all know that. In a healthy boy, open to let food through, but in the distended esophagus does not open right. Right, so this block the trap and fluid and liquid because people can't get to the stomach. Then what are the primary option for the atrocious esophagus treatment for a twisted esophagus is complex. Standard procedure are hard because of the shape. So we often try to clear the blockage first. Okay, if it is a blockage there, we have to clear it first. Then to damage part, surgery can do like esophagectomy. How does this twisted back laser lead to respiratory issues? This is the case that can lead to the respiratory issue. Okay, twisted esophagus can hold the food, and this can increase the aspiration, and it can burst this respiratory. There can be a respiratory problem, right? Aspiration pneumonia, those can be presenting, can be seen. Okay, so this tortuous esophagus, right? It's like a dilated and twisted esophagus, right? Dilated and twisted esophagus. Let's see, we can find this something, the good picture. What is esophagus? Not meaning. Yeah, can you see it's a dilated? 1 minute. Let's find out a better picture. Here, this is the one here. Esophagus showing the dilated tortuous esophagus consistent with. Let's see what they have given. Because this time some topics I don't know, but they are here end stage achalasia here. Can you see? I'll attach this picture as well. The dilated one, right? So what do you think the treatment should be like if this is like dilated, twisted, present in esophagus present? So what do you prefer? I think surgery would be the best, right? Surgery would be preferred, right, doctors? What do you think? The surgical management should be preferred because the only option we got that because we can still think about this because the thing is anyway this seems like a very serious situation, right? Very serious situation and better to do the surgical things, but I will try to find something else, but actually couldn't find a proper guideline. I went through like multiple guidelines and they have not given a proper one. Proper one. Okay, like that. So mostly this is associated with the long-term untreated achalasia. So it can see the after barium solo, you can see the dilated, this tortuous, enlarged like this, enlarged esophagus, right? Esophagus, and the treatment. So it's a achalasia associated because of that, and it's a complicated one. So I think better to go with surgical correction because like there's a no proper guideline to tell if it is this you can go with that, like there's a no guideline. That's what we can generally get an idea because of the severity and everything we can go with that, right? So that's what I have attached the treatment for the eclampsia. In here also we can think about the laparoscopic myotomy. It's a better option, right? Surgical management, yeah, like that. So I hope you get an idea because some questions there's a no proper guideline in those things that we have to find. We have to use some updated guideline, especially the surgery questions, right? If you are like, if you have any idea, if you have the proper idea about those guidelines that they also I have explained about it, because we don't have a proper guideline for this surgery. In that case better to use e-medicine is the first priority I will give. Other, if e-medicine also not mentioning, that you can use uh, sorry, you can use the other updated guideline, teach me surgery up to date or whatever they are available with the updated guideline. Okay, so HIV positive 55 all, person with right flank pain, red blood cells in urine, most appropriate initial investigation, indemnivir given. So CT, KUB, non-contrast CT, ultrasound, cystoscopy. So what do you think? They're asking most appropriate initial investigation. And what do you know? What is happening in here? A person with flank pain and hematuria. Hematuria present. So painful hematuria. So what you should think about in here, painful hematuria. It can be what? It can be infection or it can be stones, right? But here what you know about the indinavir association? What is associated with indinavir? The stones, right? The stones associated with the indinavir here. Drug-induced renal calculi represent 1 to 2% of all renal calculi. In the last decade, drug use for the treatment of HIV-infected patients have become more frequent cause of drug-containing urine calculi. Among these agents, sorry, The protease inhibitors are well known to induce kidney stones, especially indinavir and atazanavir, and more recently darunavir, right? So urolithiasis is attributed to the other PIs and also been reported in the clinical cases such as those during non-PI cases. Okay. So here again I have attached among antiretroviral. So intervenir has the high potency to cause these urolithiasis, right? Urolithiasis. So now tell me what should be the answer. What should be the answer? Patient is 55. What should be the answer? Okay, here do you remember this chart? Okay, history and examination, and microscopic hematuria and macroscopic. If it is macroscopic, you are directly going with the CTIP. Even if it is a microscopic hematuria, and according to the risk stratification, our patient, if it is microscopic, okay, age is 55, so age more than 50 years. So even here our patient is having risk, so risk factors present anyway, he is going to this CTIVP, right? CTIVP. Right, doctors, I hope it is understandable, but here you have to always exclude the exclude what, exclude UTIs. Okay, exclude the UTI as well. So from given these three options, they are. It seems like they are trying to give a hint about the investigations, like main investigation, like imaging and those things. So because of that, we can go with CTKUB. That is the most important thing.
But Dr. Sithara, in the
Yeah.
guideline in the flow chart, it's written
Okay.
either CT, IVP, or ultrasonography. Can you revert that?
CTI, doctor, I have showed in previous when I was discussing the hematuria question, I have shown they have clearly mentioned CTIVP is the best one. I have not attached it again because already we have discussed it. Have you not seen the previously we have discussed what is hematuria, the causes and everything hematuria discussed. So in that case, I have explained about the CTIVP. Okay, so please make sure those points are very important. Yes, it's day one, yeah, right? Yeah, it's different, but go with CTIVP because we don't know the recaller, the way of given this, right? So go with CTKUB and CTIVP. Other than what are the other names? CT Eurogram, right? I that day I have shown that how they can ask with different things. So non usually CTIUB. No, the same, right, doctor? CTI, yeah, it's the same, right? Meaning CTKUB. Usually CTKUB mean they have not mentioned like here I contrast or not, right? KUB mean anyway kidney ureter bladder. So yeah, without contrast, right? We are using. But if it is like given better one is what? Better one CT CT-IVP, like here that they have mentioned, IVP intravenous or CT urogram with the what with the contrast, right? With the contrast, doctors. Okay, so the here the given one is the same, non-contrast CT and CT-KUB, that is same. Okay, the same thing, not different. Okay, you get the idea, right? Dr. Society IVP. So in the name IVP, that mean IV is present, right? IV present. Right, doctors? Yeah, but here you can see non-contrast is better because it's clearly given a hint about indinavir, right? Indinavir. because that they are giving a hint about the stones, right? So stones are given, so we don't need to have the IV contrast, right? So usually IV contrast is very important in the check-in of the like excluding cancer and everything, right? But in here the given scenario, CT, they are asking most appropriate initial investigation, so non-contrast CT is a better one, right? It's depend on the scenario. Yes, CT-IVP different, then follow the same for painless hematuria. So if it is a painless hematuria, so you can go with CT-IVP. CT-IVP with contrast, okay, with contrast. And if you are very, like, if you have properly read it, in the e-medicine also, they have given two things, the non-contrast one for one answer and other case they have given the CT urogram. It's fine. The CT is the best. Okay, CT is the best for the initial. But if it is a painless, check if this is CT IVP present. If it is not, still you can go with CT KUB. Okay, because CT is the best option as the initial investigation. Okay, because not the ultrasound, right? Okay, I'm moving to the next question. Is it understandable, right? Because here they are very clearly given a hint. So you don't need IV, right, with the contrast. Is it okay, doctors? Is it okay or not? Please check the hematuria note, then you will understand, okay? Is it understandable or not? Tell me, doctors. Quickly, quickly, we have to move. Doctors? Yes, right? Yeah. Okay. So go through the question that I have attached in the previous file, the hematuria. So then you will understand, okay? So we'll move to the next question. Patient drowsy and confused, taking suclofentixol, olanzapine, and lithium, now has fever, hypertension, and muscle rigidity. Which investigation confirms the diagnosis? CK, urine drug screen, CT head. Then next question is neuroleptic malignant syndrome, best diagnosed method. So two different recallers. So what do you think? So what do you think, doctor? The first question. So what is it? Mm-hmm. Okay, we'll do this question. I'll do this question. Oh no, I have not attached the question. Oh, it's fine. I'll show a question. I have attached only this part. So yeah, so then I will explain about neuroleptic syndrome. So what is neuroleptic syndrome? That is happening in here. Yeah, so you can remember the neuroleptic syndrome from one of this picture. Okay, so you can remember it as a mean mental state. So altered loss of consciousness, drowsiness, the autonomic features, tachycardia and hypertension, then thermoregulation, hyperthermia, temperature more than 39 is very much associated with the hyperthermia. Then extrapyramidal symptoms like bradykinesia, rigidity, and tremors. This picture clearly given a proper idea about the clinical presentation, right? So, what is neuroleptic malignancy syndrome? It's a rare but potentially life-threatening reaction to the antipsychotic medications characteristic by fever, muscle rigidity, altered mental state, and autonomic dysfunction, right? So, what is the management? Okay, if they ask in immediate management, patient is taking patient is taking risperidone and patient present with these made features, made symptoms that I have explained earlier. Made symptoms, these people presented with that. So, what you need to do initially? Okay, you are suspecting what? In the management, what you can do? Is it given something? No, in the I'm asking about the treatment, like how, what you need to do initially. Here, the immediate discontinuation of the causative agent, typically the antipsychotic, is the first step in managing neuroleptic malignancy syndrome. Neuroleptic malignancy syndrome. Just discontinue because neuroleptic malignancy syndrome is a severe case. So here, sorry for that. So here, if it is a severe, it's a serious situation, so you are not ready, so doing anything. If it is only that extrapyramidal side effect only, you can follow that the reduce and the change to another drug that pathway. But here, it's a neuroleptic malignant syndrome. It's a life-threatening emergency situation, so you have discontinuation of the this causative antipsychotic, right? So supportive care including cooling measures because this is associated with the hypothermia and fluid resuscitation is crucial in the management of NMS, right? NMS. Okay, so here these symptoms, the MAID symptoms, normally occurs 2 weeks after the first dose. The key aspect of management is discontinuation of the antipsychotic drugs, right? Here, again, I have mentioned like how these symptoms are present. Extrapyramidal side effects led by rigidity, then bradykinesia, dystonia, abnormal movements, postures, tremors, temperature, hypothermia, more than 39, autonomic features, tachycardia, hypertension, labile blood pressure, sweating, tachypnea, the central nervous system involvement, drowsiness, confusion, altered mental status, coma, those things can be present. So abnormal investigation finding true not specific in neuroleptic malignant syndrome. Serum creatinine kinase concentration more than 3 times in upper limit of normal. Leukocytosis and low serum iron concentration. Diffuse globin on an electroencephalogram consistent with metabolic encephalopathy. Cerebrospinal fluid examination, lumbar puncture may be normal or have slightly raised protein concentration. CT and MRI of the brain are normal in neuroleptic malignant syndrome. Right? Okay, and we have something called the diagnostic criteria. Here, yes, diagnostic criteria here. So, diagnostic criteria, we have major criteria and we have other criteria. So, diagnosis of neuroleptic malignant syndrome based on the clinical finding, the criteria are not well defined. So, these diagnostic criteria, neuroleptic malignant syndrome. So, major criteria must have all three: exposure to dopamine antagonist drug, severe muscle rigidity, hypothermia, right? All three should be there. So, other criteria at least two of tachycardia, hypertension, labile, blood pressure, sweating, raised serum creatinine kinase, leukocytosis, and dysphagia, tremor, all that consciousness state, mutism, and the incontinence, right? So treatment here, stopping the causative agent, supportive care, prevent complications like thromboembolism, rhabdomyolysis, aspiration pneumonitis, exclusion of other medical, toxicological, psychiatric disorders, right? An antidote such as bromocriptine is sometimes required for severe prolonged neuroleptic malignant syndrome, right? Yes, bromocriptine. Yeah, that is the way. So yeah, in here in the given options, so the Western is we can check the CK, but to confirm the diagnosis, what you need to confirm the diagnosis. To confirm the diagnosis, I think, and here usually it's based on the clinical finding, the diagnosis, right? So all exposure to dopamine, severe muscle rigidity, hypothermia, and these things. This is the diagnostic criteria. Other than that, others are non-specific. But given in these all things, these all three, the creatinine kinase, CT, and those things, the better one go with CK because it can be associated with this rigidity and those things, right? So in that case, we can go with CK. This question is kind of weird though, because the problem means like they are given all the non-specific things, right? Non-specific investigation here, and they ask as to which confirm the diagnosis. Yes, EK is elevated, that's true, but that is not a specific, but the mainly to diagnose it, you need to have the clinical presentation, right? Clinical presentation. With the clinical presentation, we still can. Yes, it's a minor criteria to confirm. Actually, to confirm the diagnosis, like this is the diagnostic criteria, right? Criteria here, criteria should be there. But we don't know the question, but given in options, we can go with CK. But for me, I feel like the critically, if these three of present, that can be the best for the diagnostic, right? Exposure to hormone antagonist, severe muscle rigidity, hypothermia. Okay, in that case, I think they will give these three in the stem. They will give these three in the stem, and one criteria from me as example, um, and the leukocyte and the tremor also present. Then they can ask what you can use to confirm, because then already three criteria is fulfilled, and here and one criteria also here the tremor. And other than in that case, you can go with the raised serum creatinine kinase, right? Raised serum creatinine kinase. Right, doctor? So if we can think like that, yes, if we can think like that, this can be working, right? According to this one. Think like that, okay? Otherwise, there's no criteria as CK to diagnosis, okay? Next one. 1 minute. Sorry. Erythema diagnosis. So what is this erythema? What do you know about this erythema? Erythema. We have kind of new topics also this time, right? Every time they are giving the new topics here, also mostly related with the terminology. What do you know about this erythema? Okay, so what do you know about erythema? We'll do this question and we'll come back. 68-year-old woman present to the GP with 2 week history of mildly itchy rash under her breast. She is otherwise in good health and has no significant medical history and do not take any regular medications. Then, on examination, she appears well with vital signs within normal limit, and there are well demarcated reddish brown, slightly scalpy patches in the inflammatory folds bilaterally. A wood lamp examination revealed coral red fluorescence in the affected area. Then they are asking which one of the following is most appropriate first line treatment for the condition. So, what do you think? So, type your answers here. Type the answer. Type the answer quickly, doctors. What do you think? Quickly answer. Oh, sorry, you can't see the picture. Answers, right? So now tell me the answer. These are the answers. Just give it a try. Give it a try. Okay. Mm-hmm. Okay, let's see. Okay, the patient's presentation is consistent with erythema. Right? Okay. It is superficial skin infection caused by Corynebacterium minutism. The characteristic features include the well demarcated reddish brown patches, slightly scaly and mildly itchy intertriginous intragenous areas, right, such as under breast, under groin, and the between the toes, right? The coral red fluorescence under wood lamp examination, right? Very important. Remember coral red under this fluorescent wood lamp examination. The most appropriate first line treatment for localized erythema is topical fusidate sodium. Topical fusidate sodium. This is antibiotic. This antibiotic is effect against this organism, right? Organism. So, yeah, would be applied this. And would be applied as fusidate sodium 2% ointment topically twice daily for 14 days to warm patient that recurrence is common without addressing the preventive measures, right? Do you get the idea? So here erythrosma is a superficial skin infection that caused by Corynebacterium minutisum and frequently found affecting the intravenous areas. The topical fusidate sodium is the effective first-line treatment, right? Wood lamp examination revealed the coral red fluorescence in erythrosma lesion. So these three are the main three important things you need to remember, right? You need to remember. Here, can you see the other options? We have different tribes, interdigital between toes, intragenous erythrosma, armpit, groin, under breast, and umbilicus, then generalized one on the trunk. Right here, this is how woodlight fluorescence can see. Okay, so how to diagnose wood lamp? Now, skin examination, the long wavelength ultraviolet causes erythrosma, fluorescence coral pink color due to the chlorophyll released by the bacteria. Okay, like that. Then swab or skin scraping microscope with periodic acid shift. And these methanamine silver or gram stain may be revealed. The gram positive filamentous rods. And these C minutosime, right? And if you want more details, you can give it read from here the Dermanet. This is from this part from Dermanet, okay? And this is the one of emergency question they have given the typical presentation, and they are asking the diagnosis. So wood lamp examination you can do, right? Wood lamp examination you can do. It, yes. Okay, is it understandable? Yeah, these are new topics. Yeah, event is also there. But some topics we can't find. I think not only this question, there are more question for this topic. Please do those as well, okay? So very important. Next one, patient present with vomiting, abdominal distension and groin swelling. Previous history appendectomy many years ago. What is the next best step? Surgical exploration of the groin, ultrasound of the swelling, CT abdomen. What do you think? Okay, we'll do this question. 74-old woman attend to the ED with 2-day history of nausea, vomiting, and constipation. She has not opened bowels for 5 days, passed or fast any flutters for the 2 days, and has started to have episodes of cramps like abdominal pain. She has a medical history of Parkinson and with the appendectomy 30 years ago. Her medications include simvastatin and aspirin. On examination, she appears uncomfortable. Her vital signs are within normal limit, and examination show that the abdomen is distended, soft, and with no area of tenderness. So, which one of the following is most appropriate? What do you think, doctors? Answer for this question first. Mm-hmm. Yeah. Okay, this patient almost certainly a small bowel adhesive obstruction. Adhesions are common cause of small bowel obstruction and previous appendectomy, often decades earlier. Is often the trigger. The management of such problems should first of all focus on clinical picture and if some form of radiological investigation is considered. Which imaging would be the best appropriate? Whether resources are limited, a plain abdominal radiograph will usually provide sufficient information for the case of suspected perforation, small bowel obstruction, and the presence of foreign body. So abdominal ultrasound is frequently used investigation in emergency department and often more readily available than CT. In case of focused abdominal pain, particularly right upper quadrant, the pain is suspected gallstone disease, so sufficient diagnostic information will be obtained through ultrasound. However, in most cases, the acute abdominal pain, more useful information will usually be gained from the CT radiography. In this particular case, the plain CT scan will confirm the diagnosis and identify the likely cause of site of obstruction, right? Yeah. So here, plain CT will confirm the diagnosis and identify the likely cause of the site of obstruction, right? Then okay, give oral contrast would be erroneous as the patient may require prompt surgical intervention, and oral contrast is an obstructed gut would increase the risk of aspiration, right? That's why we are not giving IV contrast, CT, right? Okay. So a plain CT is a simple investigation to perform the case of suspected intestinal obstruction where both sides are in nature obstruction can be identified. Okay. So what is the answer for this one? 72-year-old man present to the ED with a 2-day history of absolute constipation, preceded by 1 month history of increase in constipation. What? Answer is CT. Answer is CT. For which question? Answer is CT for the e-medicine question. First, we will discuss, doctor. Okay, then we will. Anyway, after this discussion, I'm going back to our question. Okay, so I'm discussing these things to you to gather information. Okay, otherwise, no point of adding e-medicine, right? Okay, so 72-year-old man. E-medicine one, yeah, CT. Here they have clearly mentioned the plain CT will confirm the diagnosis and identify the likely cause of site and obstruction in this particular case, right? Okay. Okay, so read this question. Read this question and tell me the answer. 72. Emergency department, 2-day history of absolute constipation, proceed by 1 month history of increase in constipation on examination. On examination, his abdomen is distended and soft apart from the localized tenderness in the right iliac fossa. Nothing abnormal can be felt on the rectal examination or no fecal matter can be felt. A plain abdominal X-ray shows the gas in distended large bowel as far as sigmoid colon where the sharp cutoff and no gas in rectum. So which one of the most appropriate investigation? Tell me, doctors. Tell me. Okay. Okay, so CT abnormal. I hope you get an idea about CT, right? Get an idea about CT. Okay, now the problem is here. Yes. We'll go back to our question. So, patient present with vomiting, abdominal distension, and groin swelling. Previous history of appendectomy many years ago. What is next best step? So, what do you think in this scenario? Is it CT or surgical exploration? Anyway, ultrasound is out. So, what do you think from these two? What do you think from these two doctors? What do you think? Tell me. What do you think? Is a surgical exploration of, okay, groin. What about other doctors? Okay. And we'll try to find something. Just tell me your opinion. What do you think? What do you think? Mm-hmm. What about other doctors? Okay, here there can be two things, right? There can be two things for this obstruction, right? This bowel obstruction. So one is what? Adhesions from this small bowel obstruction, right? One is from that. Then they have mentioned something groin saline. If this groin is incarcerated or strangulated, that can cause the obstruction. But here, just a groin swelling, right? Just a groin swelling only. Is it incarcerated or not? Tell me, doctors. Is it incarcerated or not here? Tell me, tell me. Tell me, is it incarcerated or not here? Just groin swelling, right? If it is incarcerated, how it present? How it present? Yeah, here the vomiting and distension, it can be due to, yeah, is vomiting and, okay, that's the two thing, doctor. Vomiting and abdominal distension from, it give the idea about the bowel obstruction, right? And the abdominal distension. Then the groin swelling is present, right? So what are the local features that if there is a incarceration here? What are the, okay, the local, how it is incarcerated, how local it present, if it is incarcerated, is it symptomatic or not? Patient present with how? Painful, right? The area, the bulge, this swelling is painful, right? It's a painful, mainly the painful and redness also present, right? If it is incarcerated, those features also can be present, right? Yes, no coffin pulse, non-reducible, right? Non-reducible, yes. Those things can be present. But here the patient is having history of appendectomy many years ago. What is next best step? So in that case, the most priority should be what? Most priority should be the vomiting and abdominal distension, right? So what do you think in this case? What should be the priority? Is a bowel obstruction of the thinking about the think about this swelling we can think about later because at the moment there's no features of the local erythema or pain or anything, but it's here it seems like appendix due to these past appendectomy adhesive obstruction, right? It can be due to adhesive obstruction, right? Because there's just only with the groin swelling alone is not prove incarceration, right? Or there's obstruction, right, doctors? So because if it is incarceration they will give it irreducible, right? And severe groin pain, right? Skin erythema, the tenderness, right? Those things or can be associated with the severe cases like peritonitis, like, but mainly it should be give irreducible, severe groin pain, and the skin erythema, the local features, and everything should be given if it is the incarcerated hernia, right? But here it seems like mainly from the adhesive one. First of all, you have to get an idea about what? Idea about the obstruction, right? Idea about the obstruction. In that case, if the CT is the available one, so we can go with the CT abdomen, right? Is it understandable for you? Understandable. Okay, if the stem is given, even though if the appendectomy or those things, appendectomy also present, and they have given the scenario like this: patient present with vomiting, abdominal distension, and painful groin swelling, and this groin swelling is irreducible, and the skin is also red and like local tenderness, those things. In that case, that is a emergency, so in that case you need to go with surgical exploration, right? that case you can go with the surgical referral or urgent surgery, right? Because the obstruction and the strangulation both present. But here, just groin swelling is not enough to diagnose it as the incarcerated or not, right? Because of that, here better to go with CT abdomen. Is it understandable for you all or still doubtful? Tell me, doctors. Is it still okay? Is understandable or still doubtful? Okay, right? Okay. Sorry for that, doctors. My dog is giving me such a pain. He just entered my room. Okay. So, yeah, CT abdomen, right? Here also the small explanation. And please read these questions as well. And please, okay, I'll show something for the, no, for the herniation. So don't mind the background noises, doctors. You know my dog is in my room at the moment. That's why she is making some noises. Okay, I'll show then your doubts will be clear. Okay, so obstructed her. Oh no, not this one. Oh, I think I know. I'm not going to read the whole scenario, but I want to show. Mm, mm, no, not this one. Yeah, is it increase in colic abdominal pain, medical history of laparotomy, colectomy for and she examination. She appears uncomfortable. Pulse rate is 95. Abdomen is distended. General tender with low pitch. There's a fullness in right groin. There's a fullness in right groin, right? Yeah. Okay, we'll do this question. I think this is okay here. A previous 65-year-old woman present with a 2-day history of colic abdominal pain. The vomiting has not been able to tolerate oral intake for 24 hours. She has a history of chronic kidney disease, hemolysis. It's also not very good. The bowel sound are increase and tinkling. The groin has 3 centimeter tender swelling immediately below the lateral to the pubic tubercle. The serum biochemistry is given here. So urea 16, creatinine 157, GGTP 349, AST 50, or 46. Which one of the following most appropriate initial diagnostic investigation? So now tell me the answer for this question. Tell me the answer for this question. What do you think, doctors? Okay, we will go back to previous question. But tell me the answer for this question. There's a 3 centimeter tender swelling as well. Woman present with a 2-day history of colic abdominal pain with vomiting, not being able to tolerate oral intake. So tell me, what do you think? Type your answers in the chat. Quickly type your answers in the chat. What do you think? What about other doctors? Doctors, tell me your opinion. Can you see like they can twist it? And because that's why you need to understand the concept properly. Okay, here they are given ultrasound. Let's see why. because we are going to learn something new. Like the patient present with 2 day history of colic abdominal pain. 2 day history, not the acute vomiting and the physical exam suggestive intestinal obstruction. The diagnosis is supported by the finding in increased and tinkling bowel sound paired with the 3 centimeter swelling in the right groin. The location of the swelling below the lateral to the pubic tubercle consistent with the incarcerated femoral hernia because they are mentioning the tender, right? Tender, tender swelling, right? Here they are given the tender swelling and it's consistent with the incarcerated femoral hernia. The experienced clinical clinician will appreciate that the tenderness of the swelling implies like ischemia and the patient need to prompt surgical intervention. In such hand, any form of imaging will be superfluous. So, however, the real life in this patient here, they appreciate they will tell surgical intervention in that case, but then they are telling again in real life and the patient will go through a number of investigation leading to the final decision making. Most patients with intestinal obstruction present acutely with abrupt onset colic abdominal pain, nausea, vomiting, and abdominal distension. The most important risk factors for an intestinal obstruction, abdominal or previous surgery, adhesions, wall or groin area, abdominal wall or groin hernia, inflammatory diseases like ulcerative colitis, then GI malignancies. The first consideration in the patient like this is a physical examination. After the examination, it's been completed. A lab evaluation should be okay. So then, patient who present with the significant abdominal pain, laboratory evaluation typically include the complete blood count. Okay, although not specific for the diagnosis. Then yeah, blah blah. And it is a patient has been vomiting with a poor oral intake. The only investigation required will be some baseline lab investigation. It is highly likely that patient require intravenous fluid replacement prior to the surgery and need will be guided by the serum electrolyte picture. Although intestinal obstruction may be suspected based on combination of clinical examination, finding various risk factors, okay, and usually require confirm the diagnosis and identify the site of obstruction. The preferred imaging modality to confirm the diagnosis of intestinal obstruction is CT. Okay, we know that abdomen and the pelvis with contrast. Okay. To confirm this, the serum biochemistry shows the impaired renal function and this would exclude any contrast studies. Okay, in this patient, you should exclude and here they have given CT, just CT abdomen, not the contrast one they have given. Okay, while imaging is often essential part of the workup, suspected bowel obstruction, the cause of the suspected intestinal obstruction evident in this case, obstructed femoral hernia. A plain abdominal X-ray would confirm the presence of intestinal obstruction, but would not define the cause. In this case, the ultrasound examination of the groin would be confirm the presence of the femoral hernia. This imaging investigation can usually be done at the emergency setting and it is more convenient than a plain abdominal radiograph or CT scan. And these circumstances would provide all the information that is required while the urine known. So if any emergency imaging investigation is to be done in case of intestinal obstruction due to an abdominal wall hernia, then ultrasound will usually be the most expedient, right? The good one. Yeah, yeah. Previous initially, doctor, they in the previous one they are telling initially you can go with the CT. Then here they are giving to confirm it. Better to go with CT IV. Let's see. This is updated in last month. That's what I have not seen. Yeah, because otherwise, like the all the hernia part, I covered softening. Yeah, just swelling, doctor. In our case, just swelling. Just swelling. That's what I told you in there, just swelling. Yeah, here swelling. Okay, you're asking about the previous e-medicine. That's a fullness, groin fullness. Okay, we'll do that question as well. So what you learn from this question, this is last month updated question. This is a good one. So what you need to do in this case? Yeah, we will do. First, tell me what you have learned from this question. Because this is the last review last month. That means this can be a new update, something. Doctors, don't worry. I will do the previous question. Okay. For now, tell me. Uh, first, tell me what you have learned from this thing. Okay. So here they have done the ultrasound. Why? Ultrasound not for the obstruction. The first thing you need to understand is ultrasound not for the obstruction, right? So we are not doing the abdomen ultrasound, not okay. So we are doing here the ultrasound of the lung. Why? Okay, the presentation is for stable. Okay, so think like this. The in here they are giving the thing is okay. You have to understand the bowel obstruction risk causes they have given. Okay, here firstly they have given those things in the that they are mentioning to understand the bowel obstruction. Initially, you can do the plain X-ray, but the better one is CT. Right, CT, and here again they have mentioned to confirm it properly. The IV, CT, IV contrasted is the better. Then again, then they have telling if the incarceration present. So in our this case, they are clearly given incarcerated hernia because tender swelling, tender 3 centimeter swelling present, right? In that case, they're telling it's associated with this bowel obstruction. In that case, you have understands the bowel obstruction. Then to confirm the hernia, the incarcerated hernia, in that case, you can go with ultrasound, right? Ultrasound, this is the like practically we are using that, and but here they have clearly mentioned the surgical here, and like the ischemia here, the experience of clinical will appreciate the tenderness of this swelling impress like ischemia, and patient need prompt surgical interventions. Okay, in like such a hand, any from the image it will be superfluous, right? So okay, if they have given like what is most appropriate next investigation, in that case what you should go most appropriate next, most appropriate most appropriate next management, most appropriate next step in management, in that case what you prefer. If the answer is given the surgical interventions, refer for surgery as well. In that case, what you should prefer? Still, you are going with the ultrasound, or you are going with the surgical referral. What do you think? In that case, what do you prefer? Yeah, in that case, go with surgical referral because that is the most famous e-medicine question. Okay, most famous, not e-medicine, the AMC exam question. If you see an incarcerated hernia, you must refer for urgent surgical referral. You should do. Okay, here they are asking something different. They are asking what is most appropriate initial diagnostic investigation. They are asking about investigation, right? Because of that only we are going with ultrasound. Okay, here they very clearly mention. I will attach this question. Okay, I will attach this question. First of all, I will minute. Okay, go to the 1 minute. Go to previous question. Okay, I don't know this. Okay, so this question, do this question, tell me the answer, then we will discuss. Okay, then we will discuss. Okay, here's the question. 92 ED, 24-hour history of increase in generalized colic abdominal pain and vomiting. She has a medical history of laparotomy and colectomy for colon cancer 10 years ago. She take paracetamol as needed, but no longer medication or regular medications. Examination, she appears uncomfortable. Pulse rate is 95, BP 135 by 85. Respiratory rate is 20, SpO2 98. Temperature 37.2. Abdomen is distended and generally tender with a high pitched bowel sound. The fullness in the right groin. So CT images is given here. Okay, so they're asking which one of the following most likely diagnosis. Now tell me, what do you think? Okay, so do you want again the question? This is the question, and this is the CTG images. Now tell me, what is the answer? Tell me, doctors, what do you think? Then we will discuss this question as well. What do you think? Okay, what about other doctors? Quickly answer, doctors. Please give some your opinion, then we will discuss, okay? Because can you see the time? It's 5. You are taking too much time, so that's what we can't finish the records properly. Because of that, please type your answers here. What do you think? Just simple question. You can type. You don't have no one here to judge. We all are here to, but you all are here to learn something, right? So that's what. Okay, you all going with femoral hernia, right? 4. Good. CT image demonstrate the knuckle of small bowel herniation through the femoral canal, which is lies below the lateral to the pubic tubercle. This finding combined with the clinical presentation of colic abdominal pain and vomiting in elderly women diagnostic of femoral hernia. Right? Here. Okay. So then, what they have given the femoral hernia, more common in elderly women, carries a high risk of incarceration and strangulation due to the narrow, rigid femoral canal. The typical presentation as a lump below the lateral to the pubic tubercle. Through this finding may be subtle on examination. This case highlights the importance of to the physical examination in elderly patient with presenting the abdominal pain as well as value the CT images confirming the diagnosis when clinical findings are equal. Right, so physical examination groin essential to elderly patient presenting with abdominal pain refer for the bowel obstruction. CT can identify the type of location of hernia when physical examination is unclear or incomplete. Yeah. Yeah. Okay, can't our recall question be like this? Yeah, can it be right? Okay, so what is in here? So if you saw these two previous two questions, what was in your mind? Email is also given. So here, let's see. This is the last year updated. Okay. Okay, here, 74-year-old woman present to the ED with 2-day history of colic abdominal pain, distension, and vomiting. She has a medical history of hypertension, MI, with stent 2 years ago, appendectomy 22, medication include clopidogrel, aspirin, perindopril. No relevant social or travel history. On examination, she appears unwell with pulse rate 100. BP 140 by 90. The respiratory rate is 80, SpO2 98. Then temperature 37.2. Soft distended abdomen with high pitched bowel sound. There's easily reducible and non-tender right inguinal hernia. The good question. Plain abdominal radiograph show the dilated small bowel loop with air fluid level. So which one was most likely cause of presentation? You are a life savior, Dr. Ritik, all the way. You can easily find the questions, right? So yeah, I have three questions to attach. So can you see if the this kind of presentation given it's totally a adhesions right here? The same theory that I told you, if it is reducible and non-tender, it's just a normal swelling. It's not the incarcerated. But if it is tender or with not reducible, right? Then erythema, tenderness, those things is incarcerated hernia, right? Yeah, that's a good question. Okay, I will attach all of the questions there, these three, right? This one as well. Okay, and other question as well. Now your task is do all the questions today, okay? All the questions today for these incarcerated hernias and everything. Okay, no, okay. I'm not wasting too much time on this. Okay, I'll attach here. Other two I will attach it, okay, doctors? So don't worry, other two I will, it's a long question and I need to add some a note for that. So attach. Okay, so our question is just a groin swelling. They have not mentioned anything. So in that case, we can go with CT abdomen because the next they have not done anything here. Just we had to find out the is the bowel obstruction present or not because we are suspecting one, right? Oh, yeah. Okay. So we'll move to the next question. So mind blowing, right? Yeah. Mind blowing, right? Now they are adding some very weird type of questions, right? So that's what you need to concept, right? Concept. Other than it's very hard you to understand, right? Okay, now I'm going to ask a question. There's a okay, there's a swelling. Uh, Nothing present with the bowel obstruction, just a swelling. Okay, just a groin swelling, and it is a reducible, no pain, no swelling, just a reducible groin swelling. Okay, so what is the management? What you need to do? So on this ultrasound, refer for surgeon. So what do you think? In that case, are we doing anything or like X-ray or whatever? What you need to do? Like those things. Surgical referral. Surgical referral, right? Surgical referral. Because not for the urgent surgical referral, but there is a hernia present, right? Even though it's a reducible hernia, there's a herniation present. In that case, the most appropriate management is to refer this patient, right? To refer this patient because later, just a referral, okay? Then surgeon will decide their management and everything later, right? Like that. Okay, how you feel about the new medicine part about the ultrasound? Can you see the last month? I don't know what is with them. Same says I didn't like so many questions, right? Okay, next one. Patient has serum sodium 127 and urine sodium 400. What is the most appropriate management? First of all, diagnose this and the type you answer. Answer and the diagnosis. Quickly answer. These are Mary calls. Mary calls topics, okay? Most of Mary calls topics are repeated in here. Mm-hmm. Okay. Mm-hmm. Okay, we'll do this question. We'll do this question and we'll discuss. Okay. A 25-year-old man presented the ED after falling off his bicycle and sustaining head injury. He is admitted to the surgical ward for observation. 3 days after his trauma, he is alert and oriented without headache. He has been eating and drinking normally. He has no significant medical history and does not take any regular medications. On examination, he appears well, pulse 80 BP 120 by 75, CO2 98, 37.2 temperature. Urinary catheter is in place with urine output 260 milliliter over the last 6 hours. He is receiving intravenous Hartmann solution 2 liters over 24 hours. So blood test sodium 127, potassium 3.5, chloride 104, bicarbonate 26, urea 2.8, serum osmolarity 265. Then urine sodium. Okay, urine sodium is 85. So what do you think? Okay, sorry, they're asking which one of the most appropriate next step in management. So what do you think? What should be the answer? Many doctors here have done the miracles with me. So you should remember this topic is easy topic, right? Okay. What about other doctors? Quickly, easy question. I'll explain, don't worry, okay? But tell me your opinion, what do you know? Because everyone know about this disease, right? You don't need to learn it again. Okay, here. Patient present with the features consistent with SIADH, syndrome of inappropriate antidiuretic hormone secretion. The diagnosis is supported by euvolemic hypertonic hyponatremia, the low sodium and osmolarity, right? Inappropriately high urine sodium and normal renal function in the context of recent head trauma. The patient is clinically euvolemic with the normal vital signs and adequate urine output, which help distinguish SIADH from cerebral salt wasting, where patient typically present with hypovolemia, right? So fluid restriction is most appropriate first line treatment for SIADH in clinically stable patient. By restricting fluid intake, the excess water retention is gradually corrected, allowing the serum sodium to normalize, right? And this approach is safe and effective, and particularly when the hyponatremia is mild to moderate and the patient asymptomatic, typically fluid restriction to 500 to 1 liter per day as recommended, right? Okay, so when you should give intravenous saline 3%. Yes. 3% hypertonic saline. When to give 3% hypertonic saline? Tell me, doctors, when to give 3% hypertonic saline? Yes, in severe cases, right? I will explain. Okay, we'll do this question and I will fully explain the topic. 73-year-old man present to the ED. 3-day progressive confusion and mild drowsiness. He has a metastatic small cell lung cancer diagnosed 2 months ago and currently receiving chemotherapy. He has no significant medical history, no regular medications, examination. He is euvolemic, pulse 82, BP 128 by 78, respiratory rate 16, SpO2 96, and the temperature 36.7. He is confused and disoriented to time and place, but respond appropriately to the verbal command, and there are no focal neurological signs. So sodium 118, potassium 4.2, Serum osmolality 248, urine osmolality 520, urine sodium 65. They ask in which one of the following is most appropriate first line management. Now tell me, patient present with the focal neurological, no, he's confused and disorientated, and the sodium level is less than 120. So in that case, what you need to give 3% hypertonic saline, right? Patient present with symptomatic hyponatremia due to the syndrome of inappropriate antidiuretic hormone secretion. And this is common paraneoplastic complications of a small lung cell carcinoma, right? The small lung cell carcinoma. So, 3% hypertonic saline is a reasonable first step in management given the neurological features including confusion, disorientation, and drowsiness. Also, the maintained when the patient present with seizure, coma, or severe altered consciousness, hypertonic saline allow for the rapid improvement, but caution must be exerted. 1 minute. Yeah. So remember, okay, so now you have two things. Okay, mild, moderate, asymptomatic or minimally symptomatic SIDH fluid restriction, severe symptoms, or if it is the sodium level is less than 120, 3% hypertonic saline with careful monitoring, right? So general line. So now tell me what is this SIADH? What is this SIADH? So what is happening in here? So what is happening in here, doctors? What is happening in here? SIADH. It's excessive, right? Inappropriate ADH, the vasopressin, right? Is released despite of this normal plasma osmolarity, right? So what is happening here is that there's a too much ADH. So ADH function is water retention. So increase the water retention and dilutional hyponatremia can cause, right? Right, doctor. So simply the pathophysiology, how it happen, ADH is increased, right? Then kidney reabsorb but more water, right? Then after absorbing more water to the towards the blood, then blood become diluted, right? Blood become diluted. Then what is happening after that? So sorry, because of that sodium, the serum sodium level is decreased because of the dilution, right? Dilution, then what is happening, then body excretes sodium in urine to maintain the volume, right? So high urine in sodium because of that. So key finding in here, what are the key finding? So serum sodium here, SiADH. So serum sodium is reduced, right? Serum sodium is reduced. Then serum osmolarity also reduced. And what about urine sodium? Urine sodium here high, right? To compensate, they are removing sodium, right? Yeah, they are excreting sodium in urine to maintain this volume balance, right? Because of that, urine sodium is high, right? And urine osmolarity is concentrated, right? Because there's more sodium in urine, right? Because of that high osmolarity. So remember, urine high, serum low, right? Remember like that. Low serum, high in urine, right? Remember. Then it's easy for you. And there's a no edema, no dehydration, right? So usually patient is euvolemic in this case. So I have attached DI as well, the diabetes insipidus. That's something different because the most of the time they are asking to differentiate these two. That's why I have attached. Okay, so that is what happening in here. So now let's discuss about the causes. So, what are the causes? Causes can be what? It can be CNS causes, right? Can be cancers, right? There can be so many things like small cell cancer, right? There can be due to strokes, these meningitis, head injuries, right? Or there can be associated with the drugs as well. Like what are the drugs? This carbamazepine, SSRI, those things. Okay. So mild symptoms are like headache, nausea, vomiting, those things can be seen. Moderate confusion, drowsiness, but if it is a severe one, this seizures, coma can be associated, right? If it is mild or asymptomatic, you can go with the fluid restriction. here. So his serum osmolarity low. Then assess fluid status. So evolemic here also they have given what is happening and everything. Okay, so you can give it a read. Like this is all for the hyponatremia. I have attached as extra thing. But for this, it's a ADH. So mild or asymptomatic fluid restriction. Right. Then, if it is a severe symptomatic patients, or if the point that emergency has given, if the sodium level is less than the serum sodium less than 120, in those cases what you have to do, you have to go with 3% hypertonic saline, right? 3% hypertonic saline is a very important thing. Yeah, that's all for this one. Yeah, that's all. Okay. Okay, doctor. So we will take a small break. Okay, 5:23. So we will meet at 5:30, right? 5:30, a 7 minute break. Right? No, 8, no, 7, right? Okay, so then we will continue. Okay, I just turn on the recording. Okay, so here serum sodium 127, urine sodium 400. What is the most appropriate management here? They have not given anything. It seems like this kind of question, right? It can be the same question, right? It can be the same question. Yes, emergency question they are given in the exam as said. So what you can do, they have not mentioned anything about the symptoms or everything. So what you can do as the fluid restriction, right? Fluid restriction, right? Okay. So the next question. Next one, strep throat, penicillin allergy, but antibiotic. Cephalexin, erythromycin. We have done this question, right? We have done this question, right, doctors? The strep throat question. We have done right now. Tell me the answer. Okay, tell me what we can use if the patient is having penicillin allergy for strep throat, streptococcus. Tell me, doctors. We have discussed. We have went through the RCH chart, right? What is they have given the option in the guideline? What is the option they have given here? Cephalexin, right? Cephalexin. Here, if it's a non-severe immediate or non-severe hypersensitivity, you can use cephalexin. If it is a severe hypersensitivity reaction, you can go with azithromycin, right? So answer is cephalexin. We have discussed this, doctors, like multiple times in past sessions. So yeah, next one. Erythrosmite elbow, so we don't know the question. Okay, we don't know question. We don't know the question what they're asking, but I have kept it. So low back, we have discussed everything about this erythrosma. So lower back pain, breast cancer, decreased power and reflexes in lower limb, next best MRI. The only option given. So what you can do? Tell me the stepwise how you should manage this patient, because I have explained this kind of scenario. If the patient is presenting with decreased power and reflexes of lower limb, right? So associated with red flags, right, doctors? So what you can think about in here? Tell me, doctors. Okay, you are done. You have done MRI or CT. You have done something, and you have a radiological proof as well, and the clinical presentation also given the cord compression from the metastasis cancer. Okay, in that case, what you need to do initially? Have you remember? I have explained. Okay, I'm not tell you. Just go and check those questions. Okay, because you have not repeated the things. You remember the question that we have done? That we have done. I have not attached it again. Yes. Corticosteroid in which patients? Corticosteroid in which patients? Do you remember we have done the question? Question for what? Question prostate cancer with this metastasis. Metastasis cord compression. Metastasis to the cord and the cord compression happened with the neurological symptoms, and they have confirmed it with the in the question. Okay, not in the this case. In that question, they have confirmed it with the CT as well. So radiological proof also there, right? Radiological proof also there. Then they are asking what is the immediate management. No, doctor, radiotherapy is not the immediate management. That is a definitive management for the pain. That is later. But the immediately you have two options. You can go with IV steroid or IV corticosteroid, or you have the surgical decompression, right? You have surgical decompression. So if the patient is a good surgical candidate, you can go with surgical decompression. Otherwise, if the patient is elderly and with other comorbidities, you can give the IV corticosteroid, right, initially. So I remember, but you are not remembering those things. Why? Yeah, those things very important, okay? So stepwise, remember these things. So these are the key features: history of malignancy, then breast, prostate, lung, the new or worsening back pain, limb weakness, sensory changes, reflex abnormalities, bladder and bowel dysfunction. So immediate MRI, right? Radiological confirmation, start dexamethasone, urgent neurosurgical spine decompression surgery. Like it's depend on the patients. Okay. Yeah. So here we'll do this question. Seven. This is yeah. 77-year-old man present to the ED, tertiary referral hospital, from a 12-hour history of acute mid-thoracic back pain. He was recently diagnosed with prostate cancer and has an appointment with his urologist a few days ago and discussed the treatment option. So the back pain was sudden onset, worse with the movement and not associated with the sorry, associated with the trauma or force. He reported no bowel or bladder dysfunction. He has a medical history of hypertension and type 2 diabetes, and his regular medications are amlodipine and metformin. He lives at home with his wife, fully independent with all activities of daily living, and maintain active social life. Examination, he appear well. Pulse rate is 78. BP 138 by 82. Respiratory rate is 16. Oxygen 98. Neurological examination revealed mildly reduced power in the lower limb, intact sensation to light touch and pinprick throughout. So normal proprioception is symmetrical deep tendon reflex, upper and lower limb. Plantar reflexes are down going bilaterally. There are no clonus. Romberg sign is negative. Gait is normal. The only other positive finding is severe mid-thoracic back pain in palpation. They are asking which one of the following is most appropriate. So most appropriate is what? MRI of the whole spine by here, the patient is having new metastatic lesion in the thoracic spine and the potential development of metastatic spinal cord compression. Right, this is not the cord compression situation. This is before that, right? At the moment, it's not compression present, right? If the compression present is the patient is severely unwell looking, right? So then MRI of the whole spine is a gold standard. Gold standard is MRI to detect in the spinal metastasis and evaluating the spinal cord compression. It provides excellent soft tissue contrast and can detect bone marrow infiltration before any body destruction is visible on the other imaging modality. Early detection is crucial for timely interventions and prevent complications. So why not CT? Offers better body details than plain X-ray, but is less sensitive than MRI, right? Less sensitive than. I will show any other question. There was another question. It's fine. Once we get it, we will do it. Okay. I have attached another question. Lower back pain question. So here the most sensitive one is MRI, right? Very important. Very important. So please go and check the previous questions as well. Upper abdominal pain. with tenderness and rigidity. History of recurrent abdominal pain after eating food. Best diagnostic method lipase ultrasound abdomen. What do you think? What do you think in this question? Tell me, doctors. Tell me, what do you think? What is this? What is happening? Acute abdominal pain, right? Acute abdominal pain, then tenderness and rigidity. Tenderness and rigidity. History of recurrent pain after fatty milk. Fatty meal. Oh no, they have not mentioned about the fatty meals, right? Just abdominal pain after eating food. What do you think? They are in here. What do you think, doctors? Like, give me a it's pancreatitis. What about other doctors? What do you think? Okay, in here, what you can like cholecystitis one cause rigidity. Mm-hmm. Okay, so if there's a rigidity and tenderness, what does that mean? Rigidity and tenderness. What do you think? Yes, peritonism, right? Okay. So peritonism also there, right? With what they are giving, peritonism also there with they are giving but upper abdominal pain. Okay, upper abdominal pain also present after eating. So after eating upper abdominal pain present in which scenarios? We have discussed yesterday as well, associate with some fatty meals. Okay, gallstone. Okay, peptic ulcer, can it be? Yes, yeah. Here, recurrent abdominal pain after eating. Okay. Yeah, peptic ulcer also can be. Which peptic ulcer after eating? What do you think? Usually, the gastric ulcer, right? Gastric ulcer is the one that pain can worse, right? Pain can worse because the duodenal ulcer pain improve with the eating, right? Improve with the eating and usually return after after 2 hours, like later. So gastric ulcer pain was shortly after eating, right? Shortly after eating, and other than that, the like heartburn, those things are present, right? Yes. Yeah, it can be perforated ulcer, can be. But duodenal ulcer, the pain duodenal ulcer, how the pain is present associated with the meal. So duodenal ulcer pain is improving, right? Pain is improving with the eating, right? The return the pain like after 2 to 3 hours. But usually just after eating, pain is improved, right? Right, doctors? Okay. So here we have clue abdominal pain after eating. Okay, abdominal pain after eating, then tenderness and rigidity. So it's a peritonism, right? With upper abdominal pain. What do you think? Mm, this question actually, to be honest, for me, I'm having so many different like the cause as so many things because peritonism these things can be associated with those perforation, that's the one thing. And if it is like a mild peritonism, then we can think about the history of recurrent abdominal pain after eating, especially as the fatty food. Then you can think about gallstone, but here abdominal pain. What do you think? Pain with tenderness. Actually, I need more details to get an answer for this question, doctors. What do you think? Best diagnostic method. In that case, because at peritonism. Okay, what do you think about is it a pancreatitis? What do you think? Upper abdominal pain with tenderness. I saw earlier pancreatitis also given. Yes, acute cholecystitis. How it present? Acute cholecystitis. How it present? Right upper quadrant pain. Right upper quadrant pain. Yeah. Here. Okay, if it is most related with the gallstone side, we can go with ultrasound of the abdomen. Right, anyway, the lipase, we need to go with pancreatitis, but in here, pancreatitis, mm, I don't see any like a proper situation for the pancreatitis in this case. Okay, what do you think? Is it a severe case or not? Because of the like given answers, we have two options, right? We have either pancreatitis or we have gallstone, right? When you consider the given options, yes, but the scenario is not related with the pancreatitis, right? So because of that, we can remove pancreatitis, but because of the lipase out, so ultrasound of the abdomen, it can be possible if it is related with the gallstones, right? Gallstone. The my problem is the rigidity and tenderness. It's a peritonism, that means kind of severe thing. Okay, severe case, and that also still we can go with ultrasound. So if it is a peritonitis, okay, if it is a peritonitis present, what is the management? That's the problem with me. Can cause, but the thing is here, like it's more related with the other things, right? Pancreat more than pancreatitis, like because the to diagnose pancreatitis, what is the criteria? Pain should radiate to back, right? There's a diagnostic criteria, right? Hmm, what do you think? Because for me, I don't, I actually can't choose anything from here. Because there's a peritoneal irritation as well, right? That's why these tenderness and those things. Acute pancreatitis. Can it be? If it is a pancreatitis, it is chronic one and lipase is out. It can be peptic ulcer or gallstone pathology. Ultrasound. Yeah, ultrasound is better. Yeah. If it is like gallstone related, the ultrasound is the best one. Okay. Okay, uh, uh, this can be gallstone pancreatitis. What do you think? Can it be right? What do you think? This can be gallstone pancreatitis because we all know due to this gallstone is the most common factor of pancreatitis, right? It also can be. Okay. Mm, okay, this question actually for me, I need more details to mark answer, but the doctor peritonitis due to gallstone progression to acute cholecystitis. Can be, but this is not the cholecystitis presentation as well, right? That's the problem. Okay, we should not wait too much time, right? I don't think because this question is not anyway completed. We have discussed acute pancreatitis and the gallstones as well, right? Uh, I think if we will get a better question in the exam, otherwise, I don't feel like wasting time for this question. Because otherwise, if I tell this is the answer, yeah, if the answer, then you will be like thinking that the way. Because acute cholecystitis also can be a here differential diagnosis, right? Because what recurrent pain associated because of the gallstone, right? Abdominal pain can be because they are not specifically mentioned, right? Upper quadrant pain, right? Severe cases, the peritonism can be present, right? Yeah, and the imaging ultrasound is the better one, right? Okay, so that's what I'm not marking anything, but I will write down the possible causes and like that. Should not wait like these kind of weird questions much time, right? Otherwise, we can solve the better question. Prostate cancer obstructive symptoms, next best step. So, prostate cancer obstructive symptoms. They are asking next best step for the obstructive symptoms, right? For the obstructive symptoms, not for the prostate cancer. Can you see the options they are given? We have to assume the patient is already taking medication for the prostate cancer because they are asking for the obstructive symptoms. So these are low urinary tract symptoms, right? We have two types of symptoms: voiding symptoms and storage symptoms. Voiding symptoms are obstructive symptoms: hesitancy, poor stream, intermittent flow, incomplete emptying, post-voidal dripping, or flow incontinence. So storage symptoms are frequency, nocturia, urgency incontinence. The complex symptoms, hematuria, recurrent UTI, acute chronic urinary retention, urinary incontinence. So here's storage symptoms. Due to urinary tract infection, bladder calculi, urolithial carcinoma of reactive bladder for voiding symptoms, the obstructive features due to BPH or bladder neck stenosis, urethral stricture, poor detrusor contractility, right? Okay, so here we'll do some question. We'll do this question. We will go back to our question. 73-year-old man is referred to the urological clinic with 1 year history of worsening urinary symptoms. He get up for 4 times each night to urinate. He has a weak urinary stream, hesitancy, and sensation of incomplete voiding. He does not have any other urinary symptoms. His medications include hypertension and osteoarthritis of the knee, for which he takes perindopril and diclofenac. He drinks a glass of wine more evening. On examination, he appears well with vital signs within normal limit. Examination revealed no tenderness or palpable bladder. Digital rectal examination revealed a smooth, symmetrical, enlarged prostate with no nodules. Urine analysis is negative for blood leukocytes and nitrites. His prostate specific antigen 3.2. Ultrasound shows an enlarged prostate of 55 with noticeable middle lobe enlargement and post-void residual 85. Which one of the following appropriate management of plan? Now tell me the answer. What do you think, doctors? Tell me the answer. Type your answers in the chat quickly. Mm-hmm. Okay, what about the doctors? Only Dr. Sandali and Dr. Tasneem is here. Okay, Dr. Ritik also shared. Okay, let's see here. Patient present with the LUT symptoms, that's low urinary tract symptoms, consistent with BPH, right? Here, consistent with BPH. Symptoms include nocturia, weak stream, hesitancy, and incomplete voiding. The obstructive features all are here, right? Then, enlarged prostate 55 with middle lobe enlargement and significant post-void residual volume 85, right? Okay. So, tamsulosin is an alpha-1 adrenergic receptor antagonist that relaxes smooth muscles in the prostate and bladder neck, improving urinary flow. The patient should be given a trial of tamsulosin. While it can be effective for mild to moderate BPH symptoms, and it is less likely to provide adequate relief, this can be given significant middle lobe enlargement and elevated post-void residual volume. So alpha blockers generally work best for the functional rather than mechanical obstruction. Okay, so let's see about tamsulosin and dutasteride. Combination therapy can be more effective than either medication alone, right? For moderate to severe BPH, however, given in this patient significant middle lobe enlargement and elevated post-void residual volume, the medical therapy is less likely to provide the adequate symptoms relief comparing the surgical intervention. So, however, trial period with tamsulosin would be appropriate, right? So here. BPH, hyperplasia, significant middle lobe enlargement often respond better with the surgical intervention. So that is for the BPH. Okay. So post-void residual volume 80, more than 80 milliliters with the moderate severe lower urinary tract symptoms is indicated of the surgical management. That is also for BPH. So transurethral resection of the prostate remain gold standard for surgical treatment of moderate size prostate. So this is a very important part for you to remember for this BPH. But our question, we don't know just prostate cancer. They are not mentioned benign or like that, but they have mentioned something about the prostate cancer and the urinary problems. Okay, here. Then again, I'll explain from here. For alpha blockers, when to use? Alpha blockers are used to treat void in the obstructive symptoms and may improve urinary flow, although ineffective prostatic size reduction. Ineffective in prostatic size reduction, right? Not treat for the size of the prostate, it's treat in the void in symptoms, right? The symptoms, hesitancy, right? Those things. And they block prostatic alpha 1A adrenoreceptors to cause the prostate smooth muscle and bladder neck relaxation. They can also have peripheral and central nervous system efficacy similar between the selective and non-selective medications. Okay. Then antimuscarinic therapy. Antimuscarinic therapy is treat for the storage symptoms. I mean, give me 1 minute, doctor. There's another one important question for this one. There's another question. Okay. So antimuscarinic drug treat, this is for storage symptoms. Okay, here medical therapy, alpha blockers, antimuscarinics, so 5 alpha reductase, those things you can use. That is so the treatment, okay? The virtual weighting and behavioral modification, medical therapy under that you can. This is for lower urinary tract symptoms, okay? Ablative treatment, transurethral microwave therapy, transurethral needle, those things, okay? So the cavitation, that is not the prior to relieve the urinary obstruction. So for voiding symptoms, alpha blockers you can use. For the retention, you have to use the catheterization. That is something different because it also can be given associate with that, right? Associate with that. Okay, so just to show some idea, I attached that one. So here, prostate cancer obstructive symptoms. So obstructive symptoms is present. So what do you prefer? Obstructive symptoms present. What do you prefer, doctors? Is oxybutylene patch is preferred or not? Oxybutylene patch, it is for what? Which symptoms? It is for what, doctors? Tell me. It's for obstructive symptoms or something else? It is for storage symptoms, right? It is for storage symptoms, but here the problem is obstructive symptoms. So what you can give as a medications? What's the medications you can give? The best one is what? First line medication is alpha blockers, right? Alpha blockers, right, doctors? So alpha blockers are the first line medication. So you can use tamsulosin, right? Those drugs. Right, doctors? Okay. Now tell me where we should add those dutasteride, finasteride. So what is the reason of adding dutasteride and finasteride? Okay, so tamsulosin, the alpha blockers for the obstructive symptoms. So when we should add, okay, yeah, sorry for that. So when you should add those dutasteride or finasteride? When? What is the reason of adding those drugs for this tamsulosin? What is the reason? I have explained this in November recall session and other sessions as well. I can't remember the exact, but November I have a separate note as well given. When to add? Yes. Yes, to reduce the prostate volume, right? Once you need to reduce the prostate volume, in that case, you have to add these 5 alpha reductase inhibitors, right? Like that. Okay. So yeah, so alpha blockers for what? For this obstructive symptoms. So answer should be look for the alpha blockers like tamsulosin, right? Doxycycline. So like that because they are acting and relaxing these prosthetic smooth muscles and avoid prevent these obstructive symptoms, right? And if there is the case that we need to reduce the size in that case, we can add these 5 alpha reductase inhibitors, right? Yes. Okay, so that's all. So here what you should look for alpha blockers. Okay, I hope you get the idea, right? Okay, so like that. So acute limb ischemia management. Tell me the acute limb ischemia management. Easy question. It is in the chat. Yes, okay. Yeah, yeah. Yeah, doctor, there's a criteria that is under the topic of BPH, right? Yes. Please do the email question, then you will find not for this at the moment our question because that they are asking only for the obstructive symptoms. Okay. So peripheral artery disease, so acute limb ischemia. So what is acute limb ischemia? So acute limb ischemia is presented with these symptoms, right? So we have 6 P's: pain, pallor, pulselessness, poikilothermia, or we call it cold limb, and paresthesia, the sensory loss and paralysis, late indications of threatened limb, right? And these symptoms are sudden onset symptoms, right? Severe limb pain, numbness or tingling, and weakness or inability to move the limbs. Remember these things. Additional signs: sudden cold mortal skin, a rapid deterioration over hours, and limb may be tender and rigid if irreversible, right? So these are the features. Okay, so I'll show some questions. We do that one, then you will answer it correctly. Okay, here. 79-year-old man present to the ED with 3-hour history of progressive worsening pain in the right forefoot with associated discoloration of the toes and the mild reduction of the motor function of sensation. And this is his first presentation of sharp pain which occurred while at rest and the worst on movement. Minute. Okay. Was on the yeah. This is the first episode. Then sharp pain which occurred while the rest and was on movement. His medical history include hypothyroidism and hypertension, for which he take carbamazole and perindrofil. On examination, he has a irregular radial pulse 140 and blood pressure is 138/75. Other vitals are within normal limit. There are no signs of trauma. His right forefoot is cold and pale. Capillary refill time is delayed, and there's a reduced venous filling in the foot. So the right femoral pulse is easily palpable. The right popliteal, dorsalis, pedis, and posterior tibial pulse absent. The patient has slightly reduced movement of the toes and therefore with preserved ankle and knee movement. He also has a mildly reduced sensation in the toes. Oxycodone is given for the pain. Which one of the following most appropriate next step in management? So what do you think? Answer is marked. So intravenous heparin. So acute limb ischemia surgically requiring prompt vascular input. Intravenous heparin should be commenced as soon as practical to prevent the further local systemic complications. Early vascular consultation should be done by management in the investigation should be carried out, including routine blood check, venous blood gas for the lactate, and the ECG, Doppler, ultrasound, and potential CT angiography. So the definitive treatment depend on the limb viability, right? So this criteria, what we call the treatment depend on the proper treatment depend on this criteria, right? We call it Rutherford classification. Right, Rutherford classification, because this first time they have asked in October 2025 exam, and now after that they are usually asking for this one. Because of that, you need to get the idea how these classification presents the class 1 viable, class 2 marginally threatened, and class 3 immediately threatened, and class 3 mean irreversible damage can be occur, right? Sensory impairment, motor impairment, arterial Doppler sign, and venous Doppler sign. According to this, you are choosing it, right? You are choosing the what to do, right? What to do on. Yes. So we are using this one acute limb schema to assess limb viability to guide how fast vascular team must intervene and choose the type of revascularization. Because we have endovascular, open surgery, or amputation, right? If the patient is in class 3 and it is irreversible, so sensory anesthetic, motor impairment, paralytic or rigor, and arterial Doppler sound inaudible, but venous audible, but it doesn't matter. And the damage is irreversible. That means the leg is not viable. In that case, you have to amputate it, right? Like that, you need to decide. Okay, you need to decide like that. Okay. I hope you get an idea about this thing. I will attach the this thing. So a patient presented with those 6 P's and other symptoms. If you are suspecting it, you need to refer this patient for the immediate emergency revascularization. In there, you are giving the intravenous heparin and urgent CT angiogram you should done, because without doing CT angiogram, you can't plan the surgery, right? To plan the surgery, to get idea about the anatomy, you must do the urgent CT angiogram before the surgery. Then you can go with the treatment. It can be embolectomy or whatever related with the scenario, right? Like that. That is all for the acute limb schema. I will attach the note. Okay. After the session, I will attach. Okay, so next one, patient on mania having hypomania episodes on lithium decreased compliance. What to do next? Give lithium, olanzapine, risperidone, alprazolam, haloperidol. So what do you think? Quickly answer, doctors. Tell me, doctors. Tell me, what do you think? Okay, tell me what is your opinion. I'm just asking your opinion only, right? Okay, so in this case, what happened here? What is happening in here? First of all, tell me, have patient is a maniac patient, right? Patient is a maniac patient, right? On lithium. So when we are using lithium in mania treatment of the mania, for what we are using lithium for the mania treatment? When we are using lithium in mania, okay. Okay, as a mood stabilizer for a long term management, right? To long term management, right? We are using lithium, right, doctors? And here they are telling what? And here they are telling what? They are telling lithium episodes and the hypomania can see now with the lithium is decreased, right? Lithium is decreased compliance. What to do next? Okay. So that means the here what is happening? Here what is happening, the acute hypomania, right? Patient on lithium, but lithium has decreased. Because of that, there is a hypomanic relapse, right? Hypomanic relapse, right? Not severe like mania, but it's still hypomanic. Acute relapses can be, relapse is present, right? Okay, then, so how you should treat this acute scenario? How you should treat this acute scenario? What is the treatment of choice for the acute control of the this mania or hypomanic drugs? Antipsychotics, right? Yes. Okay, let's discuss. Mhm. Okay, so here, patient on lithium, stop taking the other question. Lithium level low, next best step. Okay, before that, we'll quickly go through. Principles of managing acute mania in adults and younger people. Okay, patient, determine the severity of mania symptoms, right? First of all, you need to determine the severity. Anyway, if it is a mania present, you must urgently do the treatment, right? You have to hospitalize the patient because patient need urgent treatment. Then you have to assess the severity, right? Severity of the symptoms. That is another most important thing. Assess the severity, right? Assess the severity, right? Risk to themselves or other psychosis present, severe agitation present, like need of admission, like everything you have to assess, right? Assess. Then impaired insight and judgment, and risk causing significant harm to themselves, like the same thing that I just explained. Then determine whether the patient has engaged in uncharacteristic behavior and help them to address in any consequences of his behavior. So patient with severe symptoms of mania who are danger to themselves or other require urgent treatment in hospital. The primary aim uh, treatment is what? The disturbed behavior. I don't know what Kurt. Disturbed behavior, aggression, violence to stop. I think it has to stop to cut down or something. Stop the disturbed behavior like this. Overreactivity, agitation, violation, aggression, and antipsychotic is used to rapidly achieve this. Additional intervention may be required to calm the patient who are served agitated or are behaving in a threatening or aggressive manner. Start lithium sodium valproate or carbamazepine simultaneously with the antipsychotic here. So an antipsychotic start immediately to rapid reduce symptoms of mania. Use short term Use short term, stop once acute mania symptoms remit and the patient is euthymic, right? Okay, plus here you have to at the same time you have to start the lithium or sodium valproate or carbamazepine as a maintenance treatment. Start currently with antipsychotic, continue for 6 to 12 months to prevent relapses and consider prophylaxis is needed, right? So this is the management. So lithium, sodium valproate, these things. So lithium is the most effective drug for preventing relapses in mania. The sodium valproate carbamazepine are not as effective as lithium, right? To maintaining the relapses and all, right here. Okay, so lithium carbonate immediate release 500 to 500 to 1000 milligram orally daily 2 to 3 device doses are the single dose at night. And remember the target concentration 0.8 to 1.2 millimoles per liter, depending on the clinical response and tolerability. Right? Yes. Okay, acute mania summary. First step, assess the rest, self-rest to others, just I discussed. Pharmacological, first line, rapid symptom control by antipsychotic, purpose, rapid reduce agitation, aggression, inability, and maniac symptoms. The most stabilizer, start concurrently, and use ongoing control, lithium, sodium valproate, or carbamazepine. And you should continue 6 to 12 months after remission, right? So additional short-term medications we have benzodiazepine like drugs. In severe mania, patient can be present with violent behavior, severe agitation, risk to others. So management antipsychotic immediately. Add lithium or valproate. Consider hospital admission and ECT if refractory. So maintenance after stabilization. Once patient become euthymic, so stop antipsychotic regularly, so gradually, and stop continue lithium because you already started in the acute situation and you can continue lithium, valproate or carbamazepine, right? I hope like overall the thing is understandable, right? What do you think, doctor? This is understandable, right? So we'll go back to our question and we'll discuss, right? What they are asking. Okay, here. So in this case, patient having mania, now hypomania episode, the relapse is present. In that case, what you need to do, acute situation is here. In that case, what you can give, what is the treatment you can give is antipsychotic. Now, what antipsychotic should we give? Olanzapine, risperidone, alprazolam, haloperidone. What do you think? What is the antipsychotic of choice? Tell me, doctors. Okay, I'll show what they have given the order. I think I have not attached it. How to treat acute situation. So why olanzapine? Why olanzapine? Why not the given other drugs? Okay, here we have olanzapine, risperidone, those drugs, right? Here the olanzapine, maximum dose 30. Stop olanzapine once acute symptoms have remitted and continue with the lithium or sodium valproate or carbamazepine monotherapy. Risperidone, here also the same thing they have mentioned. Aripiprazole, then what else? Quetiapine. So the first line is olanzapine and risperidone, right? Risperidone is not given. Risperidone is also given. Then what you need to do? So from olanzapine and risperidone, what to give? What to give, doctors? What to give from olanzapine and risperidone? Tell me. Tell me. Okay, in that case, what you need to know in that case, the other thing you need to know about this patient's other features, like if the patient is presenting with the metabolic syndromes, like the adverse effect. That is the place that you apply adverse effect, right? Very important. But I just remember somewhere I have attached but can't. Minute. Yeah, it's that. Okay, here. Then the drug should be designed according to the adverse effect, right? According to the adverse effect. Okay, here's the adverse effect. So, if the patient is presenting with cardiometabolic diseases like what? Diseases like the diabetes, overweight, right? In those cases, what we can give here. So we have what are the options given? Olanzapine, right? So let's take olanzapine. Olanzapine also having cardiometabolic 3 plus. When whatever risperidone 2 plus. If the cardiometabolic effect from these two, the better one is risperidone, right? Like that. You have to decide according to their given features, right? Okay, like that. So some details are missing because this is a recall, right? Because of that, better to go with, better to go according to the given scenario, right? That's what I'm not marking anything because both are both are the first line drugs, right? Both are first line drugs, right, doctors? Both are first line drugs. Is it understandable, right? Is everything it's okay, right? Okay, here. Olanzapine and risperidone both are first line drugs. It's understandable, right, doctors? So according to that only we have to decide. Okay, so what about the second question? Second question. So patient on lithium stop taking lithium. Lithium level was low. What is the next step? Lithium level is low. What is next step? Restart lithium or olanzapine. Patient on lithium stop taking lithium and lithium is low. Next best step. So now tell me what you need to do. What you need to do, doctors? Quickly answer. It's a very important question. Quickly answer, doctors. Then it's better for everyone. Yes, it's depend. It depend on the scenario. Okay. So here, low lithium levels simply indicate that there's not enough lithium in the body, right? So most commonly because why? The patient stopped taking, so because of the non-adherence or missed doses, or it was measured before the reach in the steady state, right? The concern is that lithium is no longer providing mood destabilization, so patient is at risk of maniac relapses, depressive relapses, or recurrence of bipolar disorder, right? So in that case, what you can do in here, if the patient is not having the acute relapses, right, and not having acute relapses, and the patient miss doses, or patient is non-adherence, we can restart the lithium. But if the acute presentation is given with the acute maniac symptoms given, you have to start the antipsychotic as well with this lithium, right? Yes, that is the way you have to think. Okay, that is the way you have to think. I hope this is understandable, because these are very like a little amount of the recall stem is here. Because of that, you have to think accordingly. But in here, the hypomanic episodes present. In that case, you must give antipsychotic, right? Antipsychotic. But in here, if there's a nothing present, like the acute symptoms or like maniac features, you don't have to worry. Then you can restart lithium, because of the risk, because of the low risk level mean there can be you have to there can be a risk for the relapses, right? So you have to prevent it, you have to restart it, right? So that is the way of it, right? Okay, so next question. I'll attach a small note, okay? Attach a small note. So the next question, patient on lithium. Patient on lithium, GP increased the dose as he found some episodes of mania. Now present with tremor, gait instability, and but able to stand still. Management, reduce lithium, stop lithium. Patient on lithium, GP increased the dose as he found some episodes of mania. Okay, doctor has increased the lithium. Right now, presenting with tremor and gait instability, but able to stand still. So, what is happening in here? What is happening in here, doctors? What is happening in here? What is happening in here? Okay. Is this what? Is this acute lithium toxicity or the chronic lithium toxicity? What is this? Is it what lithium toxicity? Is it acute or the chronic lithium toxicity? What do you think? Tell me, doctors, what do you think? Why acute? Why you are not thinking like this? Patient is already on lithium, right? Already on lithium. Then GP increased the dose. Then patient developed the tremor and these features, right? So what is happening in here? Mm-hmm. Mm-hmm. Okay. Okay. What do you think? Like if it is a acute one, how it present? Acute one, how it present? So I have not attached the acute part. because that is something different. Okay, that is like the patient is having overdose, right? Patient is having overdose, not like the acute, not likely long term taking these lithium medications. The acute mean like acute ingestion of like things. Okay, so here here, acute lithium ingestion is ingestion of less than 25 gram, rarely cause major toxicity. Most patients with acute lithium poison require no specific treatment except for serial measurement of lithium concentration. Okay, so toxic dose. The acute lithium poisoning rarely lead to the significant toxicity, and lithium saturable absorb and low uptake into the CNS. Acute lithium ingestion less than 25 unlikely cause a major effect. So toxic one. In acute lithium poison, patient have serum lithium concentration more than 5 millimoles per liter, but this may be not indicate the severe poisoning as CNS concentration are much lower than serum concentration, right? So here the clinical presentation for the acute one. GI effect, nausea, vomiting, diarrhea, CNS effect, tremors, hyperreflexia, ataxia, and the QT prolongation. Can be present, but it's not very common, right? Very common, but can occur in severe poisoning or arrhythmias, rare. Okay, here. So what that is how the acute presentation is presenting. Okay, now I'll show the chronic lithium. Here, the chronic lithium accumulation. The risk factors. Impaired kidney function, dehydration, age more than 50, previous lithium toxicity, drug interactions, or lithium-induced nephrogenic diabetes insipidus, or intercurrent illness, or thyroid dysfunction. Here, how it present according to the concentration is 0.5 to 1. No toxicity, minimal toxicity, just tremor can be present. So 1 to 2.5, mild toxicity, tremor, hyperreflexia, nausea, vomiting, diarrhea. If it is 2.5 to 3.5, moderate toxicity, rigidity, ataxia, drowsiness, confusions, right? This can be present. Then if it is more than 3.5, the severe toxicity present, coma, seizures. 1 minute. Just 1 minute. Okay. These severe features can be present, right? Okay, so in our case, what is happening? In our case, what is happening? Yeah, now presenting with tremor and gait instability. Okay, so here our GP has increased the dose because of the relapses, right? Now presented, not a acute overdose, right? Patient is already on the lithium and now increase the dose, and after few days or like after that, not just after that, after using this increased dose, then patient is having some tremors and gait instability but able to stand still. So this is not the acute accumulation. This is like a accumulation, right? And because of that, the toxicity has present, right? So it's here gait instability and what is the tremor, right? So ataxia or drowsiness, but patient can still stand properly, right? Can still properly. What doctors? Yes. Oh, yeah, okay, you are earlier. Okay, so in that case, what you can do, reduce lithium or stop lithium? What do you think? What do you think, doctors? If we should stop or reduce? Tell me, because this is a neurological toxicity and gait instability, little bit. Yeah, instability present, but patient still can stand it. So, what do you think? Okay, here in TG, what they have mentioned. Mm, The treatment. Oh no, not this one. 1 minute. Okay, here. The management overview for chronic lithium accumulation. The management of chronic lithium toxicity aim to prevent the permanent neurological sequelae and the kidney failure and often involve the intravenous fluid therapy. So withdraw all nephrotoxic agent including lithium and hemodialysis may be required. So monograph describe the management of toxicity due to the chronic lithium accumulation. Here's the one. Where is that monograph? Okay. Nomograph is here. Okay, not. Where's the treatment part that I took? Okay, treatment. I think this side. Okay, here. From here. Okay, so here, a serum lithium concentration expected to be still elevated. Okay, hemodialysis increase the lithium clearance, the severe cases, okay, but it's not usually required. Treat chronic lithium toxicity in patient with normal kidney function. Hemodialysis may be indicated if the serum lithium concentration is expected to still be elevated more than 1 millimoles per liter after 36 hours, or the patient is having clinical features of severe toxicity, right? Severe toxicity. That is so hemodialysis. But in our case, what you can do is the treatment of induced, that is nephrogenic diabetes, is the management overview, management of chronic lithium toxicity. Okay, the patient is taking long-term lithium therapy can be chronic toxicity if their usual doses increase. Here, Dr. Yaya, here, chronic lithium accumulation. That's what I remember. I read somewhere the increased dose is going under this chronic lithium here. The patient taking long-term lithium can be chronic toxicity if the usual dose has increased. They prescribe additional medications. Elimination of the lithium is reduced due to the kidney impairment. They develop lithium-induced nephrogenic diabetes. Here, more insidious than the acute lithium poisoning, associated with a significant morbidity and mortality, commonly present with the neurological manifestation, which can take days to weeks to solve. So, recovery is significantly delayed if when serum lithium concentration has decreased to the subtherapeutic concentration. So, management. Um, to prevent the permanent neurological kidney failure, withhold all nephrotoxic agent, including lithium. So in that case, what you prefer is stop in or reduce. What do you think, doctors? What you can do in here? What do you prefer? 1 minute, I will show. Remember, there is a good question. Lithium, right? No, no, no. Mm, Flexin, cousin hypernonate, not this one, doctor. So I think my preference is stop lithium to prevent further problem. What do you think? You still going with reduce or stop it? Because TG is clearly mentioned. TG is clearly mentioned. What do you think? Because at the moment, the immediately you have to stop the lithium, right? Then what you can do, you have to check the serum lithium level, right? Serum lithium. Now, according to that, you can decide the further management. But the next thing should be stop it, right? Why should not reduce? Because what is happening here? Neurological toxicity, right? Neurological toxicity. So I don't think we should reduce it. Because the only just only like a mild case we can think about it, like no toxicity or like just only tremor. But here gait instability also present, right? Not only these tremors. In that case, I think better to stop it immediately, right? Yes. With what is, yeah, it's better to stop. Withhold all nephrotoxic agent, including lithium, because their aim is prevent to further permanent neurological problems and kidney failures. For that, just will withhold all the nephrotic agents, right? Including lithium. What do you think? So, because just not only the tremor is present, right? Not only the tremor is present here, we have the gait instability as well. Because of that, I'm going to stop lithium. Do you all agree with that, or do you have any other opinions? What do you think, doctors? Probably we have the some toxicity, right? Toxic effect is there. Tremors, then ataxia, right? Instability. Those things can be present. For that, we need to stop. Tell me, doctors, I'm gonna how you should finish this file. Otherwise, if you are not interacting to the session, tell me what do you think? What do you prefer? Because these are recalls, right? Not the theory class. So I need your opinion as well, right? So we are doing a discussion here. So what do you think? Only okay. So I'm asking you still want to go with reduce or stop? Yes. Because the problem is we not only tremors present. If it is tremors only, there's a no toxicity. In that case, you can reduce it, right? You can reduce it. But here they have mentioned the gait instability as well. In that case, it is like two of these neurological symptoms present. Because of that, there can be some kind of toxicity. Because of that, at the moment, better to stop the lithium, right? Because you have to preserve the kidneys, right? Because of that, I think better to go with stop lithium. If otherwise, like a tremor only, because there's a no effect here, tremor only, then there's a no toxicity or minimal toxicity. In that case, I think we can go with reduce, like a general knowledge, right? No, no, I'm not upset. Upset, doctors, because you have to continuously participate, right? Because in the exam, I'm not there, right? I'm not there. You have to answer by yourself. Okay. Today you all are like very bored. Why? What happened? I should be the one who is bored, right? Because you are not answering. I'm the only one who are talking, right? Yeah. Okay, next question. A patient came with 2 episodes of lightheadedness. Yes. Yeah, doctor. Yeah, that's the problem. Because the here toxicity present. Management of lithium chronic toxicity aims to prevent. Here, but if it is no toxicity, only with tremor, in that case, we can think about reduce, like generally I'm telling. Otherwise, better to go with this one, right? Yeah. A patient came with 2 episodes of lightheadedness on many drugs, indapamide, timolol, metformin, empagliflozin, and digoxin. Heart rate 42 ECG shows second degree heart block. Which drug is responsible? We have discussed this, right? Yes, we have discussed this case. So, remember the timolol and digoxin question. What you should mark? What is the answer? What is the answer? Digoxin, right? So we have discussed this question. Why timolol? Why timolol? Why timolol, doctor? Here you have second degree heart block. And what? I have explained this one. Digoxin and timolol. What is the effect in digoxin? It can increase the vagal tone, right? Because of that, there can be a slow conduction through this AV node. Like beta blockers also can be cause, but the digoxin has a very good connection with these AV blocks, right? These AV blocks. We have discussed this question. Timolol can cause the bradycardia and hypertension. Yeah, I agree. Yeah, I agree. But when we consider these two, the digoxin is a better option, right? Because it is very much associated with this second degree. Because second degree AV block. Previous question they have given the AV block because it has a greater connection with second degree AV block than this timolol. Day 5 question 2, right? So please go and check it again. I have explained everything for that one. Next one. Male has husband who is HIV positive. What is the best way to protect himself? Wear condoms during the sexual intercourse. Do not engage in oral sex. Okay. What do you think, doctors? We have discussed, doctor, this digoxin question. So please check it. Okay. The explanation, the recording as well. So male has husband HIV positive. What you can do to prevent it? Is there any better answer? Anything better than these two? Yes. Yeah, okay. Husband who's HIV positive. What is the best way to protect himself? Okay, there's a couple. They have recently got tested HIV and one is positive. Is one is positive. And what is the best way to the husband is positive. What is the best way to protect himself? It's just only the we are just only advised wear the condoms using sexual intercourse. So that is all. Or do we have something else? Yeah. Okay. Okay. This is the main question. Yes. Next, we'll discuss how you should decide the like a suspected or confirmed exposure cases, the management. Okay, because you need to know, but you need to know the viral load is on treatment, or like you need to have like uh, a lot information about the patient. Okay, so the risk of HIV transmission from single exposures determine the type of exposure and HIV status of the source, right? Determined by the type of exposure and HIV status of the source, or likelihood that the source is HIV positive of their status is unknown, right? So testing requirement. If the source is HIV antibody antigen negative and unlikely to be in window period, so no further follow-up testing for the source or exposed person is required. Very important. Then, if the source is HIV antibody antigen positive or HIV antibody antigen negative and likely to be in the window period, the exposed person should have HIV antibody antigen testing at baseline 4 to 6 weeks and 3 months after exposure. In people who do not receive HIV post exposure prophylaxis, the likelihood of the seroconversion is 6 weeks after exposure using the current standard assay. Uh, and HIV antibody antigen test is very low. The people that receive HIV PEP should have HIV antibody antigen test in 3 months after exposure, as there is some evidence of delayed seroconversion in this cohort, right? So, post exposure prophylaxis. Seek expert advice from a physician experienced in the management of HIV. Consult local guideline before initiating the post exposure prophylaxis for HIV. Recommendation for post exposure prophylaxis against HIV depend on the exposed person's risk factor of acquiring HIV. If indicate, okay, I have not attached that one. The being gay or those things are there. Okay, I'll show that one. First, we have the list of things post exposure. Okay, here assessment of the HIV part. This is for all, right? Go HIV. Okay, here. Okay. They have changed it, right? Oh, it's the same thing. Yeah, it is here. Okay, okay, here. I have attached that part as well. Okay, in there. But they have mentioned recommendation for post-exposure prophylaxis depend on the risk and the recommendation here. Okay, it's depend on the route of the intercourse. If it is anal intercourse, okay, anal intercourse, source HIV status and PEP recommendation. Source HIV positive and not taking antiretroviral treatment or taking treatment but viral load is detectable or unknown. In that case, the patient should take PEP recommendation, three-drug regime, right? So next one, anal intercourse, source HIV positive and viral load undetectable. In that case, PEP not recommended. PEP not recommended if the source provide the reliable history, adherence to antiretroviral therapy, and reviewed by the regular and has no other sexually transmissible infections, right? So HIV status of source unknown. You don't know the source in that case. Very high risk prevalence population like men who have sex with men, MSM, and the drug injectors, right? They are very high risk for them. You have to use under high prevalence the three drug regime. So this is a very high prevalence. So high prevalence mean men who have sex with men from high prevalence country. So PEP not recommended unless the sexual exposure was receptive anal sex or insertive anal sex and the person is uncircumcised. If so, use two drug regime, right? Okay, so if it is a vaginal intercourse, source of HIV positive, source HIV positive, not taking no drugs, and viral load also detectable low unknown. So you had to use three drug regime. HIV positive, viral load undetectable, no need. HIV status is unknown in that case. Like that, you have to use men who have sex with men use three drug regime for sources from a very high prevalence population, not recommended, right? Not recommended. And I'll show about the oral sex because they have mentioned in oral intercourse as well. Okay, so oral intercourse. Uh, HIV positive and not taking antiretroviral treatment and or taking treatment but viral load is detectable, not recommended. PEP not consider two drug PEP only for the receptive fellatio with ejaculation where the exposed person has a significant visible oral mucosa trauma. HIV positive but viral load undetectable anyway, not recommended. HIV positive and status unknown and high prevalence population, not recommended, but consider two drug regime, right? This is for the oral intercourse as well. So yeah, that is the that is the general idea for this PEP. PEP, right? So I hope you get an idea about PEP. We have to add this part. Okay, I'll add it later. Okay, we're here. Do not apply people taking HIV pre-exposure prophylaxis. And if the exposed person was taking PrEP, pre-exposure prophylaxis, at the time of exposure, then you have to use post-exposure prophylaxis after non-occupational, and there's something else. Okay, inform people receiving post-exposure prophylaxis of potential adverse effect. Like in different month, they are asking from different cases, right? Sometimes they are asking from the injuries in the hospital, right? Needle stick injury, those things. Sometimes they are asking from these HIV positive post exposure prophylaxis. So we'll do this question and get the idea. 28% of the sexual health clinic regular HIV post exposure. No, doctor, this is not too much to memorize. Just remember, like everything is kind of same. So is it PO patient? So exposed mean after that, right? Yes, post, right, doctors? Exposed case. The husband is HIV positive and recently he got to know, right? Yes, exposed, that mean post. He reported unprotected sexual intercourse 24 hours ago with a casual partner whom known to be HIV positive and do not take treatment. The patient prescribed daily exposure prophylaxis but admit to be missing tablet. He stated that his last tablets was 72 hours ago and has had 3 doses in the last 7 days. Has no significant medication history and take no regular medications. And he has not non-drug allergy. Examination appears well with vital signs within normal limit. Which one of the following is most appropriate management? Now quickly answer for this question. Then I'll explain easy question. Within tell me the time period within how long from the exposure you should give these drugs, within how long? Good, 72 hours, right? Yeah. Sorry. Here, this is a clear indication for PEP. Despite the patients being prescribed pre-exposure prophylaxis, the patient has not adherence to the pre-exposure prophylaxis treatment, right? Because of that, patient is risk at getting HIV. Because of that, patient need PEP as well, post-exposure as well, right? Even though he is taking pre-exposure, not adherence to the treatment, only took like 3 doses in last week, so it's a risk. So, post exposure prophylaxis as soon as possible within 72 hours of exposure, even though the patient is prescribed PrEP, its poor adherence means he cannot rely on its protective effect. So, PEP typically consistent with 3 drug antiretroviral regime take for 28 days. So, after initiating PEP, the patient should be counseled about the importance of medications and adherence, medication adherence, both for the PEP and future PrEP use. The follow-up HIV testing should be arranged and consideration given to the sexual transmitted infection screening, right? So, yeah, I hope this is understandable, right? Hi, doctors. So here, we don't know the like the source. It's known to be positive and not on treatment. So anyway, it's depend on the situation. But here, in our case, you have to get an idea about this patient first, right? Husband who is HIV positive. Best way to protection is, this is like a okay. What do you think in here? So we can advise where condom use, right? We have to advise their condom use. Other than that, what we can give after, if the patient is after the like sexual intercourse, then they have got recently like know that the partner is positive, past is partner is positive, then at the moment you have to go with post exposure prophylaxis, right? Okay, that is the like the scenario, right? Exposed scenario. Okay, and like that. Okay, if they are coming like this, okay, there's a couple and the coming with partner is positive and they are not mentioning about like recent sexual activities, so like they are going to marry or something like that. In that case, what you can give, in that case you can give pre-exposure prophylaxis, right? If they already have the sexual intercourse, to prevent the immediately, what you can do is post exposure. But for the later, the future prevention, you can start the pre-exposure prophylaxis, right? Pre-exposure prophylaxis. It depends on the scenario, right? It depends on the scenario, right, doctors? You get it, right? What I'm telling, right, doctors? Right? Yeah, it's depend on the scenario. Okay. So, um, okay, so I will attach a small note here because the depend on pre or post. If they are like going to have a plan, going to have a family, and they are going to marry it, like in the future plans, if they are and husband is HIV positive, so what you can do is uh, pre-exposure prophylaxis. I will show pre-exposure prophylaxis question as well if it is only available. Then it's very good to you to understand pre-exposure. How it is present in, let's see, exposure. I don't know, doctor can't find how it present. CPREP. Hmm. Okay, I need the same thing. Let's see what is the scenario. 28 GP. No significant medical history disclosed that had a sex with a multiple male partner in the last year and typically use condom. Yeah, his last sexual contact was five days ago, and with a new male partner during the which they did not use condom. They state that they plan to be exclusive and engage in unprotected anal intercourse. He revealed that his new partner is HIV positive and on treatment but has not been attending regular follow-up for the appointment. He expressed concern about the contracting HIV and ask about the prevention strategies, right? Here they're asking prevention strategies. On examination, just appear well and physical examination, everything normal. Sexual HIV and STI infection screening, normal, negative. Full blood examination, renal function, everything is negative. Then which one of the following is most appropriate next step? So what do you think is a condom use only, prescribe pre-exposure prophylaxis, prescribe post-exposure prophylaxis, advise abstinence from the sexual activity? All the answers are here. Right? All the answers are here. Defer decision until the result is available. So what do you think? Type your answers in here. I'll attach this question as well. It's also good. So what is the answer? Type your answer. Easy question. Doctors, what is your answer? You can hear my screen, right? You have to answer, right? You just read the question. Okay, okay, so here. Here, men is planning to unprotected and anal intercourse with partner who are HIV positive and not attending the regular follow-up. The partner viral load therefore unknown, meaning the undetectable viral load cannot be assumed. This places the patient at the substantial ongoing risk. The future risk, right? If they are going to marry or having to intercourse, right? Intercourse, and in this case, they are very clearly mentioned this patient is STI or everything is negative. So patient not having the not the patient, this person not having any STIs, but he is going to have relationship within future with the patient who is having HIV. In that case, you had to give pre-exposure. If the scenario, if they have, if the patient your patient is exposed or like had a intercourse with HIV positive patient, then you have to give the post exposure. Two different scenario, and you have to answer according to what they are asking, right? It's a easy question. It's a good one because everything is very clearly explained. That answer also here. Advise abstinence from the sexual activity, right, Dr. Grace? That answer also here. Okay, I'll attach this one. What? But he's already exposed. What? That's great. What he already exposed. So we don't know the scenario, doctor, right? Okay, then they can give the scenario like this. There's a couple. What is your mistake? No, you have not done any mistake, right? Yeah, okay. So here they can give like this. Okay, there's a couple. Both are STIs negative. Okay, I'm giving like a scenario. Both are STI negatives earlier. Then recently, the one partner has had another sexual activity in a party, and he got HIV. Okay, he got HIV. That is the one thing. Even though they are married, like those things can be given in the like sometimes they are given, right? They have unprotected sex in a party. Then after that, this male got HIV, right? Like that. So in that case, then they had the sexual intercourse with the former partner, and like right after that they both are coming here, and the husband is already HIV positive, and like he exposed to that husband because recently he got the HIV. In that case, you have to initiate the post exposure prophylaxis, right? And the other scenario, there's a couple, they are planning to have the family or having sexual intercourse, like unprotected sexual intercourse in the future. And like they are, one is HIV positive, they are asking for the one who doesn't have the disease, asking for the prevention from getting HIV. In that case, pre-exposure prophylaxis, right? Simple. Play a husband. Yes. Cheating, right, doctors? Yeah. Okay. Like that. It's depend on the scenario, but it's fine. You know the theory and remember these things. Also, these are not hard thing. Just write down anal intercourse. Uh, then anal intercourse, HIV positive, no taking treatment, no antiviral. Then write down three drug regime. Then positive, low viral load, no recommended. Then here write down the very high prevalence and high prevalence. Here also the kind of same, right? Same thing is ongoing, but the intercourse here, the anal and vaginal are the most high risk. Then oral one low risk, right? Like that. So yeah, I have seen they have asked from anal oral recently in 2025, anal oral and the vaginal intercourse as well. Other than that, I have not seen something. not related to the inter. Oh no, then they have asked about the injuries as well, right? Injuries as well, as I remember, because in TG they are mentioning not only the intercourse, they have mentioned about the semen splash to the eyes. Like so many things are here given, but you don't need to remember everything. Non-occupational, occupational mucous membrane, non-stick, like the needle stick injury, those things. Okay. Okay, next question. So our case, I will attach a small note for this question. Okay, next one. Next one. A patient present after brief loss of consciousness, ECG normal and blood sugar level is normal. Which investigation should every patient with syncope have? Which investigation should every patient with syncope have? CT brain, EEG, ECG, echocardiogram. What do you think? What do you think, doctors? So syncope can be associated with what? Associated with what disease? It can be associated with the arrhythmias as well, right? Arrhythmias as well. So because of that, what you can go with like all the cases? Better to go with what? ECG, right? Better to go with ECG. Do you all agree? All the, I don't think in all the cases. No, 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 not they. Oh, wait. They are not asking about this question here. Patient present after brief loss of consciousness, ECG normal, and BSL is normal. They are asking which investigation should every patient with syncope have? Not this patient. Not this patient, okay? They are asking every patient with syncope have. So in that case, from given option CT, no need. For every case, no need. EEG, no need. ECG, it's easier and non-invasive. Like we can do the ECG, right? Yeah, ECG. Can you see how they are asking the questions? So many distractions are given, right? They are giving a scenario and asking something else. That is how AMC, right? Yeah, that is the way of AMC. Okay. So next one, patient develops sudden pleuritic chest pain and dyspnea after surgery. Investigation of choice of hemodynamically stable. Patient develops sudden pleuritic chest pain and dyspnea after surgery. Investigation of choice in a hemodynamically stable patient. So what is the investigation of choice? What is this? Patient develops sudden pleuritic chest pain. What is it? Pulmonary embolism. Okay. So, what is the most appropriate one? Most appropriate one investigation of choice? Yes, it's CTPA, right? It's CTPA in stable patients. We have discussed about the pulmonary embolism, right? I will show a scenario of the pulmonary embolism. Because I explained, but I will show a question. Okay, here 62 ED. Then patient with the shortness of breath and pleuritic chest pain, positive for COVID-19, SARS-CoV-2. Then she has a history of emphysema and use of fluticasone vilanterol inhaler. On examination, she appears mildly distressed. Pulse is 110. Doctor, please read this question. I'm getting a call. 1 minute. Hello, doctor. Sorry for that. I got an urgent call. Yes, so that's that. Okay, here. Periodic chest pain, SARS-CoV-2 infection 8 days ago positive. History of emphysema and use of fluticasone vilanterol inhaler. Examination appear mild distressed. Then pulse rate is 110, BP 135 by 85. Respiratory rate 24, SpO2 91, temperature 37.8, chest is clear to auscultate, jugular venous pulse 2 centimeter above the sternal angle, no leg swelling, no tenderness. Blood pressure, blood test reveals C-reactive protein, D-dimer 2.5, here C-reactive 85, hemoglobin 135, WBC 8.5, platelet 450. Plain chest X-ray demonstrates the bilateral patchy infiltrate consistent with the viral pneumonitis. Which one of the following is appropriate? Next investigation. So here, CTPA. There could be a number of explanations for this patient's symptoms, and most important to consider the exclude would be pulmonary embolism, right? For that, I'm going to do the CTPA right here. CTPA is the most appropriate next investigation. The patient has significant risk factor COVID-19 concern symptoms, chronic chest pain, tachypnea, hypoxia, and elevated D-dimer warrant the definitive imaging, right? So why not this ventilator perfusion scanning is alternative to CTPA, but the less suitable for the COVID-19 patient due to the risk of aerosolization during the ventilation phase and likely the abnormal chest imaging. Right, so I will attach the new guideline as well. I hope everyone is aware about it that the according to the usually they are in like if the patient is presenting with this shortness of breath, they are initially doing what? Initially doing the X-ray, right? X-ray and they're excluding these lung pathologies. Then only we are going with the definitive investigation, right? I will attach that part as well. Then you can give it a read because mainly the problem was in pregnancy, right? Pregnancy is the one that there's a most problematic one, right? Pregnancy and these pulmonary embolism and DVT questions, most weird questions, but I will attach those part as well, okay? Because this is not a pregnancy. Next one, patient present with a syncope during the exercise. Here, one thing that otherwise I'll forget it. Next one, patient present with a syncope during the exercise. ECG is abnormal. Which cause must be excluded first? Syncope during the exercise. ECG is abnormal. Which cause must be excluded first? Vasovagal syncope, cardiac arrhythmia, structural heart disease. So yes, it's important to exclude the cardiac arrhythmia and a structural heart disease, right? Easy question, right? So next one. 45-year woman present with the recurrent episodes of the right upper quadrant pain occurring after the fatty meal. She's now has upper abdominal tenderness. What is the best initial investigation? Serum lipase, abdominal ultrasound. The previous question, recurrent episode of the right upper quadrant pain. Here, the right upper quadrant pain occurring after the fatty meals. Here, this is the proper question. So, yeah. Oh, we could have not discussed there, right? Because the proper question is here. Waste of time, right? Earlier, okay. So, yeah, next question, gastric carcinoma. Biopsy shows the inflammatory cells, but no H. pylori. Next step, repeat biopsy, gastrin level, triple therapy. So, what do you think? What do you think here, doctors? What do you think in this case? Gastric carcinoma biopsy shows inflammatory cells, but no H. pylori. Next step. Okay, we'll do this question. Previously well, 52-old man, present with a 3-month history of dyspepsia. He has a 20-pack year smoking history and drinks 2 glasses of wine a day. He does not take any medications and the physical examination is unremarkable. Undergoes gastroscopy and found to have a large 30 millimeter gastric ulcer with irregular raised edge and on the lesser curvature of the stomach. The ulcer is biopsied and the chronic inflammatory tissue identified. The rapid urea test is positive. He started on the triple therapy, esomeprazole and two antibiotics. When reviewed 4 weeks later, his symptoms have significantly improved. Which one of the following is most important key step for the management? What do you think? In here, what do you think? What about the doctors? Why repeat endoscopy? Why? Why you should repeat endoscopy? Why? Why? Reason? Reason? What is the reason? They already done gastroscopy, right? Okay. Given the gastric ulcer and severe concerning features of endoscopy, large size irregular margin, the most important action is repeat endoscopy to check the ulcer healing and exclude the gastric malignancy. Even though the initial biopsy shows the benign changes, only insufficient sampling and false negativity are possible. It is important to check that the ulcer healed and, if not, to repeat the biopsy to exclude malignancy. Unlikely duodenal ulcer, the possibility of malignancy and the need for repeat endoscopy should be considered for all gastric ulcers, although in some patients with low risk features, a repeat endoscopy may be required. A repeat rapid urea test can be also be performed at the time of endoscopy to confirm the H. pylori. Right, that is something else. Okay, so we'll go back to our case. So, what you need to do in here? Gastric carcinoma, biopsy shows inflammatory cell, but no H. pylori. So, there's inflammatory cell is present. So, here gastric carcinoma. Anyway, they have diagnosed the gastric carcinoma, uh, and the biopsy shows inflammatory cells only. In that case, what we can do? What we can do, doctors? What about other doctors? Biopsy shows inflammatory cell. Do we need to repeat the biopsy because the carcinoma is present? Gastric. Okay, I don't think this is the actual carcinoma. I think gastric lesion or ulcer should be there because this is the way of recall are telling, right? It's telling like a gastric carcinoma question. Biopsy shows inflammatory cells, but no H. pylori. Next step. So this can be like kind of same scenario, right? It can be some ulcers, right? The recall is suspect in a cancer. Then they have done the biopsy, but biopsy only shows the inflammatory cells, right? So in that case, after the healing this biopsy, we can do the repeat of the biopsy. That is a one scenario. What do you think, doctors? Because this question is not like a very good question with a good stem. In that case, you have to imagine like how should it present, or do you have any idea? Like, what do you think? Yes, still, yeah, that's what I'm telling the same thing. I am telling the same thing, right, doc? Because the inflammatory cell, right, not showing any, it can be due to false, right? Like the place can be, like not the actual accurate place, right? Or it can be like the other scenario that I told you, like a gastric ulcer. Because we don't know, because recall is still in, like he mean it can be like gastric carcinoma question. Biopsy shows something like that. So what do you think? So I feel like the repeat biopsy is the best option. What do you think, other doctors? Because this can be something superficially taken the samples, right? Superficial, like a wrongly taken sample can be, right? Or maybe they can give the scenario like the patient is weight loss, patient is presenting with that virtuous nodule, right? Like something related with the gastric cancer, some features related with the gastric cancer. And they can give like after doing the initial endoscopic biopsy, they only see the inflammatory cells. But you are very you are like having a good suspicious about this is a gastric cancer. In that case, I think better to repeat it, right? Better to repeat it, because sometimes it previously you could have taken like the improper samples, right? Like that there can be different things, right? So because it can be false results sometimes in that thing, I think in that case I think better to repeat. Oh, better repeat with the biopsies in different places, or like more deeper biopsies, right? Like that. Right, doctors? No, okay. Why gastrin level, Dr. Helena? Why? What is the reason of going with the gastrin level? So where we are using the gastrin level? Where we using the gastrin level? Sorry, something very different, right? The gastrin level. Solinger, what we call is a DS, right? Solinger-Ellison something syndrome, right? Yes, Solinger, right? Yeah. In that case, they are clearly given, right? The refractory ulcer, like a multiple ulcers, right? It is not resolving from these, the PPI, those treatment, right? So something different scenario, right? Something different scenario. In that also, in that is the scenario we are going with this gastrin level, but not in here, right? Not in here. Yes, it is multiple ulcers. Yes, multiple ulcers and not responding to the PPI, right? Something like in here. I feel like that the early explanation I told you. Because of that, better to exclude biopsy, exclude to identify this gastric carcinoma, because only show the inflammatory cells, right? Can be false, mistakenly, or the wrong place. The biopsy like that can be. Here, malignancy must be always considered in case of gastric ulcers. This is for gastric ulcers. So, patient has vomiting, abdominal distension, and groin swelling. Previous history of appendectomy. Many years ago, we just discussed this question, right? We just discussed. So, next step, they already not mention, find out about the bowel obstruction. So, initially, you can go with CT abdomen, right? Next one. A farmer with epigastric pain and X-ray given with the rim of calcification. What do you think? Rim of calcification and X-ray given. Epigastric pain. We have discussed about the hydroid cyst, right? Earlier we have discussed about hydroid cyst. I have explained all the ECG. Not sorry, not ECG. The imaging how the CT present, right? How the daughter cells present in CT and the X-ray, the calcified rim, how it present, like everything I have explained. Okay, so about the hydroid cyst, the treatment and the management, all the things I have explained. Then hypercalcemia, increase parathyroid hormone, increase TSH, next investigation. So full blood count, ultrasound of the neck. What do you think? So the problem is increase TSH here. Increase TSH also. Increase TSH mean what? Hypothyroidism situation also can be seen. And other than that, main scenario is present what? Hypercalcemia, increase PTH. Okay. Next investigation. Okay, so why ultrasound and why full blood count? Why you are thinking this way? Why Dr. Helena full blood count? Why Dr. Tasneem ultrasound? The reason why you are thinking the way. What is the reason? Ah, okay, okay. Sorry, sorry, doctor. Sorry. Yeah. So, what is the answer for this one? What is the answer for this one? What do you think? Okay. Okay. So in this scenario, what you can see, hypercalcemia, increase PTH. What does that mean? Hypercalcemia with increase. Okay. Primary hyperparathyroidism. Okay. Possible adenoma. Mm-hmm. Then, then they have given raised TSH. Raised TSH. So why raised TSH? Yeah, if there's a raised TSH, we are suspecting hypothyroidism, right? Hypothyroidism. Okay, in this case, what is the main concern? Main concern at the moment, because they have not mentioned anything with the hypothyroidism features. They are given the main problem is what? Hypercalcemia. Hypercalcemia. They are in the root of the hypercalcemia investigation, right? So next, what you can do? Next, what you can do, because they have not mentioned anything about the hypothyroidism case. We have to find it out. But next thing, what do you think? What do you prefer? Do we need to find out is there is an adenoma, sorry, hyperparathyroid, sorry, because of the hyperparathyroidism, do we need to find out there is a parathyroid adenoma or not? Yes. So what is the best investigation? What we should do to find out it? What do you think? What do you think, doctors? What do you think? Yes. Do you remember they have asked one question in May, right? In May, okay, yeah, maybe first. But if it is the most appropriate one, the best one to understand about this parathyroid one is what? This sesame bee, right? Okay, I'll show. I have attached this one. Okay, this is the here sesame bee parathyroid scan is a procedure or nucleic medication which is performed the localized parathyroid adenoma which cause the hyperparathyroidism. Adequate localization of parathyroid adenoma allows the surgeon to use the minimally invasive surgical approach. Okay, hyperparathyroidism is typically discovered by the presence of hypercalcemia and it's associated with the symptoms. So PTH level are also typically elevated but may be within normal limits but inappropriate in the setting of hypercalcemia. So hyperfunctioning parathyroid gland are solitary adenomas in most cases, while multi glandular diseases like hyperplasia or multiple adenomas are seen in 15 to 20% of instances. So these TC99M sestamebe is the most commonly used radio pharmaceutical for parathyroid scintigraphy, and it accumulates due to the uh, due to the increased number of mitochondria present in the hyperfunction in parathyroid gland, right? So what do you think in here? Do we need to do the ultrasound? What do you think? Your opinion? Okay, 1 minute. Let's see. Okay, let's see. Is there anything that they have given? So I have searched already, but I don't think because it's a clinically confirmed, right? It is clinically confirmed, and later. Mm-hmm. It's a very old guideline, by the way. Okay. Diagnosis is made by documenting hypercalcemia, the presence of elevated or inappropriate normal serum PTH level, and fraction urine excretion of the calcium. The fractional excretion of calcium is calculated as urine. No need that part. Then, in order to yeah, the effect of the fluctuation in the dietary calcium intake. Okay, morning urine calcium overnight fast 24-hour urine calcium collection. Niacinamide calcium should be here also not mentioned. Not well understand. Not mention anything. Mhm. Not mention. Okay, this is let's see, even here also mention. No, no need. I'll try to find something. A mild symptomatic or even asymptomatic disease is now the predominant clinical presentation. Therefore, appropriate lab investigation established the diagnosis. Okay, so we know that part, right? So yeah. So clinically, we can diagnose it without doing this system maybe scan, right? Once you get to like because the primary one suspected, then you know there can be like adenoma, and then later, because that is diagnosis, then later you are deciding the treatment and everything, then you can do the sestamibi scan and find the location by using that the contrast media, right? Okay, recommended. I don't know. Not mentioned about sesame. Oh, doctor. So yeah. Mm, okay, so given options, we can go with ultrasound. Given option, you can go with ultrasound, but if they like clearly ask in next investigation, it should be this sesame scan, right? That is the best option for this one. Usually ultrasound is okay, but if they have given system maybe can go with that. Okay, given that, go with that, because that is the most important one to diagnose, like to understand the location of the adenoma, right? Because the primary one is anyway adenoma. We can clinically, not clinically, laboratory wise we can diagnose it. Then I think better to go with the systemic scan. But if it is not present, ultrasound also we can think about it. But and really, the problem is hypercalcemia at the moment. But increased TSH, that also a problem. But in here we are on the pathway of this parathormone. So just I'll try to find something. If I can find, I will attach. Okay. Next question. Routine check for hypercalcemia with elevated Parathyroid vitamin D normal, TSH point above the upper normal limit. TSH above the upper normal limit. Okay, still normal range. Next investigation here, ultrasound of the neck only we got. Same question. Next one, patient has a diabetic mellitus, consumed alcohol at a party yesterday. Today they present with shortness of breath, abdominal pain, and vomiting. Arterial blood gas analysis shows pH 7.2, bicarbonate 8, PCO2 20. What is the diagnosis? DKA, HHS, acute pancreatitis. Ethynyl glycol toxicity. What do you think? What do you think, doctors? Quickly answer. Okay, what about other doctors? What about other doctors? Okay, why DKA? What are the features? Here you can see it has a DKA. Why doctors? Why DKA? Okay. Metabolic acidosis is ongoing, vomiting, kusumal breathing. Yes. Good. Okay, here let's discuss. The patient having metabolic acidosis with respiratory compensation, right? pH 7.2 acidemia, severe metabolic acidosis, bicarbonate, PaCO2, respiratory compensation with kusumal breathing. That's why it's 12, right? The symptoms are classic. Diabetes, vomiting, abdominal pain, shortness of breath, right? Kusumal breathing. So usually associated with the type 1, young patient, polyuria, polydipsia, weight loss, dehydration, abdominal pain, vomiting, confusion, drowsiness, kusumal breathing, and ketones and hypoglycemia. Those are associated, right, in DK. So, yeah, here's a scenario. You can give it a read, right? You all know how this DK present, right? DK present. Diabetic, the key features are hyperglycemia. Hyperglycemia, significant elevated of the ketones, right? High anion metabolic acidosis and clinical signs of dehydration. These are the clinical features of DKA. And what else you need to know? Okay. Here, it is important to note that that DKA can be the initial presentation of type 1 diabetes, especially in young adults. So, the history of alcohol consumption may have exacerbated the condition or mask the early symptoms. And the treatment for DK involve the fluid resuscitation, insulin therapy, and cross monitoring of electrolytes, particularly potassium. This patient will require admission for the management of DK. That's something different, okay? And determine if it's new onset. So you can give it a read, okay? And give it a read, but this is for extra thing. Remember, in younger patients, sometimes DKA like kill directly. The DKA can be present without diagnosing type 1 diabetics, right? Because some, as here, because of the alcohol consumption, there can be exacerbation of these symptoms, right? Okay, so what is the management? Fluid resuscitation, diabetic ketoacidosis, the management. Following the primary survey, approach the unwell child ABCDE method and addressing the issue and are identified. Assessment of the circulation in this case would reveal the signs of moderate dehydration. Sankana, this is something different. Okay, this is that DKA with dehydration features. Okay, doctors. Remember, because insulin infusion also part of treatment, but remember, do not give insulin infusion before fluid resuscitation initiated. Insulin administration without adequate replacement can increase the risk of cerebral edema. So because of what, fluid resuscitation should be the first, right? Important. Okay, so we'll go to our question. So they're asking, it's DK, easy question. Next question, history of falls in elderly women, diabetic history, but glucose was 5.1 normal. Cause as DKA, HHS, acute pancreatitis, hypoglycemia, and stroke. What do you think? What do you think, doctors? Is patient is having hypoglycemia? Is patient having hypoglycemia? 5.1. Is 5.1 hypoglycemia? So what is hypoglycemia level? Hypoglycemia, it's less than how much in adults? Less than 4. Less than 4. Okay. Episodes, yeah. Can it be? Hmm. Okay. What else? What else, doctors? Here, what are the options? DKA, HHS out because the no presentation. Acute pancreatitis? What do you think? Not associate the force. What about stroke? Can stroke associate with this force? Tell me, doctors. Because the at the moment blood glucose is normal. Can be associated with, right? Other than what stroke, you can think about the arrhythmia, right? Or the static hypertension, right? These are the other causes. In here, so like given in the options, the stroke is the only one who makes sense, right? Right, doctors? So what do you think? Because the options are like very weird. Okay, these are the common features, okay? Now, when the elderly patient present with fall, always think about these common reversal, stroke, cardiac arrhythmia, syncope, orthostatic hypertension, medications, adverse effect, infection, mhm, hypoglycemia, and peripheral neuropathy and poor balance. Peripheral neuropathy and poor balance. Okay, these are the things. But in from this given stem, the only option we can go with stroke, right? We can go with stroke, but always like very careful about the stem because this is a very like little, I don't know, feel like not a better option, but still we don't have any other option as well. Next one, glucose 48, not acid, ABG, sodium 125 diagnosis, plasma cortisol level 24 by CTH, synactin simulation test. What do you think? Glucose 48. Glucose 48 mean how many? Glucose 48 mean, is it normal, low? What do you think? What do you think, doctors, in here? Is it 48 or 4.8? If it is 48, if it is 48, it is normal or not? You can tell it as 48 milligrams per deciliter, right? Because usually in the other questions we are using in millimoles per liter, but if it is 48, we can think it can be what? It can be milligrams per deciliter, right? Can be, doctor, right? What do you think? Mm-hmm. Yes, if it is 48 milligrams per deciliter, you can think about it as 2.7, the estimated value 2.7 millimoles per liter. So that is hypoglycemia, right? Other than that, here what you have, sodium 125. Sodium also, what happened to sodium? Is it reduced or normal? Sodium also reduced, right? So if we think this as the hypoglycemia and hyponatremia, yes, but you can think what should be it? Primary adrenal insufficiency. Can it be, right? Because we don't have any other way to think. That's why the glucose 48. It can be what milligrams per deciliter, right? Because otherwise 48, right? Yeah. Mm-hmm. Okay, so here blood glucose 48, you can take it as a milligrams per deciliter because usually in Asian countries we are using like that, right? So in millimoles per liter, 2.7, that means hypoglycemia, sodium 125, hyponatremia. So what do you know about this Addison's disease? It's autoimmune destruction of adrenal cortex, the primary one, right? So it can reduce the cortisol and aldosterone. So remember, additional. Additional means the reduce, right? Reduce of these cortisol and those things. So key features: fatigue, weight loss, postural hypertension, hyperpigmentation, nausea, vomiting, and abdominal pain. Right. So blood test, you can see cortisol has reduced and ACTH has increased. Right. So aldosterone decrease, hyponatremia, hyperkalemia, hypoglycemia. Right. So here's a picture how it presents. So, okay, now we'll do this question and we'll go back to our question. 32-year-old woman present to the ED with 6 month history of progressive fatigue, weight loss 5 kilogram, and darkening of her skin. She reports feeling dizziness when standing up quickly. She has no significant medical history and no medical history and take no regular medications. Examination appear unwell. Vital signs as follows: pulse 100, BP 100 by 60. In supine and 80 by 50 in standing, respiratory rate 16, SpO2 98, then temperature 36.8. Skin examination is performed. Investigation reveals the sodium 130, potassium 5.3, and this is the image. Okay, they're asking which one of the following is most appropriate next step in management. Now tell me the answer. What do you think, doctors? What do you think? Quickly answer. So, what is the answer? What is the answer? Doctors. Okay, not answering. I sure. So, serum cortisol and ACTH level. The patient present with classic symptoms of signs suggestive Addison's disease, also known as primary adrenal insufficiency. Right, primary adrenal insufficiency. The most appropriate next step is management of the serum cortisol and ACTH level, right? So these tests are essential for diagnosing of Addison's disease and differentiating from the secondary adrenal insufficiency. So in Addison's disease, the monitor cortisol levels are typically low. while ACTH levels are elevated due to the lack of negative feedback, and it's a result of equivalent. An ACTH stimulation test may be necessary to confirm the diagnosis. The oral glucose tolerance test not indicated. So, what about 24-hour urine-free cortisol test is more commonly used in diagnosis of Cushing syndrome, right? CT of adrenal gland may be performed later to investigate the etiology of the Addison's disease, particularly to rule out the infections or metastasis. However, it is not the most appropriate next step. Once Addison disease has confirmed, treatment typically involves the lifelong replacement of glucocorticoid and mineralocorticoid, patient education about stress dosing, and the need for medical alert identification crucial for the managing this condition, right? Yes. So can you see the hyperpigmentation here? Hyperpigmentation, what you can see in here. What is the picture shows doctors? Because these are associated with the hyperpigmentation, right? Okay, so here, so when to use these uh, ACTH stimulation test? So when to use this one? Okay, here. ACTH stimulation test, also called short synaptin test, is a gold standard confirmatory test for the primary adrenal insufficiency. This synaptin ACTH is administered and cortisol level are measured at 0 and 30 minutes. Right. In Addison disease, there are minimal or no increase in cortisol level due to the adrenal cortex dysfunction. Right, doctors. So after confirming the diagnosis, the morning cortisol ACTH level, plasma renin activity, and the electrolyte should be checked. Right. CT of the adrenal gland may be considered to exclude the infiltrative or infectious cause. Right, doctors? Is understandable. Right? Okay. Okay, so we'll move to the next question. We'll first to our question. So yeah, here in here, what you should check. What you should check, doctors? Is it plasma cortisol level or synaptins stimulation test? What do you think? Tell me, it's depend on what they ask. It's a confirmatory test is what? Short synaptin test, right? Okay, I'll show here. Serum cortisol and ACTH level. Here, the most appropriate next step in management to measure serum cortisol and ACTH level, essential for the diagnosis addition disease and differentiation from the secondary adrenal insufficient. Okay, if they ask what is the initial investigation, what is it? Initial investigation. Initial investigation is what? Initial, what you need to check? Initial investigation. Tell me, doctors. So, morning serum cortisol, right? The plasma cortisol level. It's a screening test, right? It's a screening test. But for the like confirmatory one is the synaptin stimulation test to diagnose. To diagnose, better to go with synaptin, right? Synaptin for the diagnostic, the confirmatory, the gold standard one, right? Yes. And so we don't know what they're asking, but because of the diagnosis, we can think about that. The diagnostic confirmatory. Okay, so yeah, we'll go to the next one. Okay. So patient with serum sodium 127, urine we just discussed, right? We just discussed this one. So patient with hemicolectomy and had diabetic history, insulin, lantase, glagreen, 12 units every day. What is correct before surgery? Withhold 6 units subcutaneous, 6 units subcutaneous. So what we can do here? So what do you prefer? So what is a glagreen? Glagreen is which type of insulin? Which type of insulin is glagreen? We'll go stepwise. Which type of insulin is glagreen? What do you think, doctors? Okay, 1 minute to put the charger. Okay, long acting. So what is the answer? What is the answer here, doctors? What is the answer? So in here, what is happening? Patient had hemicolectomy and has diabetes history of insulin. Glagreen, 12 units every day. What is correct before surgery? They are telling patient had hemicolectomy. I think patient is going to do the hemicolectomy, right? Okay, so what do you prefer? Withhold or 12 units or 6 units? Mm-hmm. Yes. Why you should reduce the dose here, doctors? Why? So we all know Glagreen is a long-acting insulin or basal insulin, right? So and here the hemicolectomy is a large large surgery, right? So it's a major surgery, not the large major surgery, right? And the patient is fasting, right? Okay, patient is fasting and patient is on Glagreen, the long acting before the surgery. What do you need to do? Okay, uh, can we withhold? Can we withhold? Can we withhold, doctors? Tell me, can we withhold? If we withhold, what is happening? If we withhold, because this is logical, you have to understand, right? Logically, according to the thing. What do you think? Logically, you have to understand. Tell me. Try. Can't withhold, right? You should not withhold. Why? Why you should not withhold? Okay, so we'll go one by one. Okay. Step one. In this question, identify the given insulin, right? Need to identify the given insulin. So it's a Glagreen, right? So Glagreen is a long-acting insulin, right? So its job is what? Control blood glucose between meals and overnight, prevent ketosis and excessive glucose production by the liver, right? It is not given mainly to cover meal, right? So what happened before surgery? The patient is fasting, right? Patient is fasting because it's a major surgery. Since they are not eating, they need less insulin, right? But they still need some basal insulin, right? So why not withhold? If the basal insulin is stopped completely, blood glucose can rise significantly, right? Risk of ketosis, especially in type 1 diabetes, right? Increase the risk of perioperative complications. To prevent the complications like ketosis, we should not stop it. Why not give full 12 units? So tell me why you should not give this 12 units. Because the patient is fasting, right, given in the full blood dose may increase the risk of hypoglycemia during the surgery because there's a no food, right? So there's a no food. So then how much you should give? So the recommended amount is reduce the basal insulin dose about to 50 to 80% while the patient is fasting. So in here, our usual dose is the 12 units. So the given option is what 6. That means 50%. So in this option, we can go with the 6 units, right? 50 to 80%. So under that, we can go with this one, right? Is it understandable? So in this kind of questions, like if you are bad at these insulin types and everything, just go step by step. Then only you will understand. Okay, understand. Okay, this provide the and this like half dose can provide enough insulin to prevent ketosis, limit hyperglycemia, and reduce the risk of hypoglycemia, right? Because you have to think if I stop, what happened? Like that. Okay, next one patient dry eyes, dry mouth, anti-RO, anti-La positive, already used in artificial tear, but still joint pain and fatigue present. The systemic features next management, hydrochloroquine. We have discussed this yesterday, right? Yesterday we didn't have the option we didn't have that the still has joint pain and the fatigue these symptoms, but here now we are having. So next one, HIV positive person with right flank pain, red blood cells in urine investigation. We have discussed this one. Here CTKUB today we just discussed. Okay, now tell me this question. Patient present with sore throat and fever. One day later, they develop hematuria and proteinuria. Anti-streptomycin or assault is negative, and they most likely diagnose IgA nephropathy, acute glomerulonephritis, renal calculi, post-streptococcus glomerulonephritis. So, what do you think? Tell me, doctors, what do you think? These are easy question. Okay, we'll do this question, then you will understand. To a boy with the came to GP after noticing dark color urine for 2 days, dark color urine hematuria. He has had a sore throat, runny nose for the past 4 days, and he has no significant medical history and take no regular medications. Immunizations are up to date. Examination appears well. Pulse 85, BP 1 1875. Temperature 37 by 37.2. Throat erythematous with enlarged tonsillitis. Tonsils and urine analysis shows 3 plus blood and 1 plus protein. They are asking most likely diagnosis. So, what do you know? Okay, here. Patient present with the classic features of IgA nephropathy, macroscopic hematuria occurring simultaneously with the upper respiratory tract infection. So we call it synpharyngitis hematuria. Synpharyngitis hematuria. So IgA nephropathy is the most common form of glomerulonephritis worldwide and typically present in the children and young adult, right? So if it is post-streptococcus glomerulonephritis, if it is presented with after 1 to 3 weeks, right? 1 to 3 weeks after streptococcal infection, right? If it is Gott's-Pasture syndrome, it's presented with hemoptysis as well, right? Hemoptysis and hematuria, everything is present like that. So give it a read. Okay, give it a read. So IgA nephropathy, easy question. It's a very easy question. I have attached another question as well. Only these two present there. 1 minute. Yeah, here and remember this part as the definitive diagnosis of IgA nephropathy requires a kidney biopsy showing mesangial IgA deposit. However, in patient with typical presentation and mild disease, normal blood pressure and minimal protein observation with regular monitoring may be appropriate initially. So remember here the investigation to how to confirm the disease and the management also there. Next one. CT shows the probable left-sided hydronephrosis. What is your next step in management of this patient? Continue current management. We don't know the current management. Yeah, IV fluid analgesic. What do you think? And the next one, a child come with abdominal pain. Ultrasound shows hydronephrosis treatment. So that day also we have discussed about hydronephrosis, right? How it present, what are the clinical features and everything. And the treatment should be always depending on what depending on its severity and what are the associated things. Because I will give example. There's a patient presented with fever, hydronephrosis. Then patient is having uh, li- stones, urinary stone as well. Urinary stone present. Patient is having hydronephrosis and patient is at the moment presenting with the fever. In that case, what you need to do, if you are very familiar with this question, because this is asked in March, sorry, May and March as well. Yeah, March also as May. This has asked. What do you think? What is the next step in management? Next step in management. Patient with what? Patient with the pain, pain and ultrasound confirmed there is a stone and hydronephrosis also confirmed, and patient presenting with the fever and patient is unwell. Next step is what? What you need to do? Yes, you will do the urinary decompression by urinary stent, right? Urinary stent. So that is the answer. Can you see that also nephrosis scenario associated with other scenarios, right? It depend on the scenarios and what they are asking, because like only hydronephrosis most of the time is present with some other scenarios, and that time we have to understand the scenario and answer accordingly. That is a best example I can give, because if you type in the e-medicine and you can find it very clearly. Okay, like that. And okay, and here we have discussed the presentation and the how X-ray present and how CT present, right? Do you remember there's a hydronephrosis CT question like that? Okay, and I got this from the that one of question. So after identifying hydronephrosis on ultrasound, the next appropriate step would be to perform a voiding cystourethropy VCUG to grade the VUR if not already done. So this information is crucial for determining the appropriate management, which may be include the prophylactic antibiotic or surgical intervention depending on the severity. Okay, here can you see the normal mild hydronephrosis, moderate. So here, if it is a grade 1, pelvic dilation. If it is a grade 2, pelvis plus, calyceal dilation. If it is grade 3, pelvic calyceal dilation, and medulla is short and thin. So grade 4 mean the pelvis and calyceal dilation. There's a no medulla. Can see here like that. Okay, depend. And yeah, and I have get a note from there's another guideline. So hydronephrosis in children. So dilation of renal pelvis and calyx due to urinary tract obstruction. So common causes, it can be associated with vesicoureteric reflux. This is can give vesicoureteral reflux, uteropelvic junction obstruction, posterior ureteral valve in boys, and ureteric stone. This is rare because this is a pediatric case. Symptoms: abdominal plank pain, palpable abdominal mass, recurrent UTIs, vomiting. So, renal ultrasound is the first line. So, then after that, you can do this MCUG that I just explained to confirm it, right? Like that. So, if asymptomatic mild observation, neurological follow up is enough. If UTI present, you can go with the antibiotic. Symptomatic obstruction or severe nephrosis, drainage, surgical management depend on the scenario, right? Depend on the scenario. This is like a general idea for this one. Okay. Yeah. Yeah, this is the question that I have explained. Hydronephrosis question, patient with fever and these things. So give it a read, okay, for this question. So next one, child with jerky movement and limp and fast eye movement also has a diffuse mass in the right flank. Faint diagnosis is a neuroblastoma and Wilms tumor. So what do you think? Is it Wilms or neuroblastoma? We have discussed about both of them, Wilms and neuroblastoma. So what do you think? What do you think how the Wilms tumor present? Okay, what about other doctors? Quickly tell me. What do you think? Okay, here. So what are the okay? They have given what? They have given right flank and the diagnosis and having diffuse mass in right flank. So one side it present right flank. And what about child jerky movements and on the limbs? What is association? Where you can see these jerky movements. What is the associated disease? Because like Wilms tumor is like mostly asymptomatic, right? Wilms tumor. So what about neuroblastoma? Symptoms is what? So you can see the lump in abdomen, right? Other than that, clinical presentation. Usually, like this neuroblastoma can be in, like in simple. Doctors, 1 minute. I need to. Sorry for that. Okay. So, what do you think? The movements, jerky movements, and limbs and fast eye movements. So, what do you think about this case? What do you think? Like associated with what? Because like in Wilms tumor, Wilms tumor, most of the time asymptomatic, right? But in here, the neuroblastoma, usually this neuroblastoma can be in like anywhere in the sympathetic nerve chain, right? Sympathetic nerve chain. Right, doctor? So here what they have given, so myoclonus, right? So jerky limb movements, the clonus is present, right? The rapid eye movement, it also clonus, right? Apostoclonus and this is jerky limb movement myoclonus. So when we consider with these two, what is the like most important thing in neuroblastoma or Wilms tumor? Sure. Yeah, we have opsoclonus myoclonus neuroblastoma. So associated with the neuroblastoma, I'll show because mainly associated with what? Okay. Disorder, half of these cases occur in children neuroblastoma. Neuroblastoma patient with OMS usually have better oncological outcome. Okay, so here it can be associated with this syndrome, right? The neuroblastoma, the opsoclonus myoclonus syndrome. Right, doctors? So because of that, the only option we have to go with is what? This neuroblastoma, right? Because of the associated syndrome, right? Yeah, like not the all the time it should be the bilateral, like can be seen in like one side as well, right? So that is the problem, right? You got arise to go with the this Wilms tumor, but here the symptoms and associated syndrome and consider with this opus myoclonus syndrome, so mainly associated with the neuroblastome. Okay, that's a good thing. Okay, so 8-year-old boy with uh, bewildered face with right side arm stiffness, chewing and swallowing behavior during the episode of last for 30 to 60 seconds with minimal drowsiness. What is the treatment? Lamotrigine, sodium valproate, ethosuximide, levetiracetam. Levetiracetam. What do you think? What do you think, doctors? Quickly answer. What is this? What you can see in this scenario. So which type of seizure is this? Which type of seizure is this? Which type of seizure is this? Yesterday also we have discussed about this one. Temporal, right? Focal seizure, right? It's a focal impaired awareness seizure, or we call complex focal seizure, right? So what is the answer? Yesterday we have decided to go with what? Here yesterday we have decided, here the last week review, because of that we decided to go with this carbamazepine, right? So I'm not explaining this again. So the answer should be carbamazepine, right? I do remember. So I have attached that one, I will add, okay? Understandable, right, doctors? Because I'm not taking too much time because we already discussed about this temporal lobe epilepsy. Here I have attached the highlighted part as well. Okay, so like that. Next one, a patient present with a generalized tonic-clonic seizure followed by persistent hemiparesis. What is the most likely diagnosis? Patient present with a generalized tonic-clonic seizure followed by persistent hemiparesis. So what do you think? Tell me, doctors. Okay. What do you think? Mm-hmm. Okay. So what is thought paralysis? We'll go one by one. What do you know about those things? Thought paralysis. What do you think? So here what they are mentioning, generalized tonic-clonic seizure followed by persistent hemiparesis. Persistent. So generalized tonic-clonic seizure present, then persistent hemiparesis. So how to understand is it thought paralysis or not? So what are the things that you need to understand to get an idea about is it thought paralysis or not? What you need to know? What you need to know? Because these are very important things. Most doctors are not thinking about these things. Okay. Here, if it is, how to understand if it is. Okay, so define the thought paralysis. Define the thought paralysis. Weakness present in how long? What do you think? Weakness. How long should be there for thought paralysis? Tell me, doctors. Thought paralysis. It's very important to know. How long? 1 minute. Just. Your messages are very late. Mm-hmm. Up to 48 hours, right? Okay, here. I will explain. You have to understand different things. Okay, this question I will add as thought paralysis, and because everyone know about this stroke, right? Okay, here. So, what is thought paralysis? It's a thought paralysis is a temporal focal neurological weakness that occurs after seizure, usually after focal seizure or generalized tonic-clonic seizure. The features weakness or paralysis of the one side of the body, hemiparesis or hemiplegia, occurs immediately after the seizure. We also have aphasia, visual loss, sensory deficits. So consciousness gradually improve and post-ictal state resolve. So the duration usually minutes to hours can also last up to 48 hours and completely resolve, right? So if this weakness is resolved within the minutes to 48 hours, we can go with thought paralysis. If this weakness persistent or worsening, then you can think about the stroke, right? Cerebral infarction, right, doctor? So there's something else I want to tell about. What do you know about this HHE? What do you know about these HHE? Hemiconvulsion, hemiplegia, epilepsy. I have attached this for like extra knowledge. Okay. So what is it? This HHE is a rare consequence of prolonged focal status epilepticus in the infancy and early children. Involves sudden unilateral focal motor convulsion followed by ipsilateral hemiplegia and epilepsy. Okay. So what is happening in here? Acute rhythmic body shaking primarily affect the only one side of the body. Hence the term of hemiconvulsion. This is immediately accompanied by complete loss of strength, paralysis of the same as the convulsion, hemiplegia, and later chronic focal drug-resistant seizures. I see. So hemiplegia is usually permanent but may disappear around 20 cases where the seizures are most often simple partial. Okay, so what is it? Then diagnose neuroimaging studies have revealed the acute unilateral edema in the affected brain hemiparesis with swelling often progressive to the cerebral hemianstrophy, not the proper stroke or anything, just the cerebral edema only. Okay. It's cerebral edema only. So hemiconvulsion, hemiplegia epilepsy is an uncommon pediatric epilepsy syndrome marked by sequential focal febrile convulsion seizures, hemiplegia, and chronic epilepsy affecting only one side of the body. It's like an extra knowledge. Okay, usually this can be seen in around before 4 years, as I remember. A most simple 1 minute. Early childhood followed by hemiplegia. Yeah, this condition primarily affects children younger than 4 years of age, with onset commonly occurring between 5 months to 2 years of age. Okay, 2 years of age. That is a like extra thing for especially children less than 4 years. Okay. In here, you can have the prolonged these unilateral febrile seizures. That's we call hemiconvulsion, the prolonged one. Okay, and it is followed by the persistent hemiplegia. So both are persistent, prolonged and persistent. Okay. Is it understandable, right, doctors? Okay. So this is something else for the pediatric population. So in here, present with generalized tonic-clonic seizure followed by persistent hemiparesis. So you have to think about what? You have to think about a stroke, right? You have to think about a stroke. Right, doctors? So that is the point. And if it is less than 48 hours, so you can think about thought paralysis, right? Right, doctors? So yeah, infarction. Right? Okay, we'll move to the next question. Is it understandable, right? Okay, so yeah. So early man fell unconscious in a chair while watching TV. Had weakness on one side of limb upon awakening. After sometimes had seizure diagnosis, thought paralysis, cerebral infarction, epilepsy. What do you think? What do you think, doctors? In here? Mm-hmm. And about the doctors? Okay. Okay. So, in early question, what was the question? It's a generalized tonic-clonic seizures followed by persistent hemiphagocysis, the earlier one, right? Now what is the woke up with hemiphagocysis, later develop seizure, right? Later develop seizure. So here what is happening? Here what is happening? Patient is having first what having here unconscious in the chair while watching TV. The stroke or some hemiplegia is present, unconscious is present, right? Then man fell unconscious in the then TV had weakness on the one side of limb upon awakening. Okay, so upon awakening, one side of weakness. Then after sometimes, patient had seizure. Right, patient had seizure. So here, what you have to think. Here, what you have to think, doctors. Here also, what do you think here? It also like we can think about a stroke, right? Because stroke also associate with these seizures, right? Elderly man fell unconscious while watching TV, woke up with weakness, hemiphagocysis present, after developed seizure, right? So stroke and this is secondary seizure, right? A stroke and this is secondary seizure because the problem is this stroke can cause this seizure. Because of that, this is a secondary seizure, right, doctors? So why not epilepsy? Why not epilepsy? Why not epilepsy? Because it associated with this hemiparasis, right? Right, doctors? So not like a proper scenario. It's associated with this thing. I think better to go with infarction, right? Infarction. Right, doctors? Infarction. Is it okay? Here I have again attached about thought paralysis. Okay, this should be in previous question, not this one. Okay, here.